A very pleasant good morning to all here. It is so wonderful to see everyone here on a Sunday morning, and it is my great pleasure to invite everyone to the second day of our magnificent academic journey. I hope today equips everyone with great insights which can augment our knowledge. Today's first session is pediatric cardiac surgery.
May I invite the chairpersons to the stage, Dr. Mustafa Janil, consultant and lead pediatric cardiac surgeon, Metromed International Cardiac Center, Kozhikode, Kerala. Dr. C.S. Jodhimuthu, senior consultant, pediatric cardiac surgery, Indraprastha Apollo Hospitals, New Delhi.
One second.
So, to begin our session, I would call upon Dr. Anila sir to discuss about something which is quite common, decision making and management in adult ASD.
At the outset, let me thank the organizers of IACTS, Dr. Jayagumar and Dr. Vinitha for giving me this opportunity. And it has been a pleasant stay, and the organizers have done a fantastic job of setting up this program. My congratulations to them. So today's talk is about one of the simplest lesions in cardiac surgery, that is atrial septal defect. Now, ASDs have the potential to close by themselves, become reduced in size, remain stable for years. Both are amenable to surgical and transcatheter closure, but they also can develop pulmonary artery hypertension, irreversible PVRI, heart failures and arrhythmias. My today's talk will be centered around second-M ASDs and sinus venous ASD. Now, in the assessment of patients with ASD, the important things we should be focused is on the functional class. It's important because it has a direct impact on the outcome of the patient, especially long term. ECG findings of RVH, atrial arrhythmias, SA and AV node dysfunction, cardiomegaly and pulmonary vascularity in chest X-ray, because always be careful about a patient who has a large ASD, relatively small heart and a dilated pulmonary arteries. That is a combination which you don't want to take up for surgery. Echocardiography, it could be 2D, 3D, transesophageal or contrast echo, essentially to delineate the anatomy, the shunt, PA pressure and ventricular function. And exercise testing, that is saturation at rest and at peak exercise, will give an idea about the reversibility of PVR. And cardiac catheterization to assess the shunt and PVRI. So most of the patients are selected for procedure on the basis of echocardiography, where echo is used to study the anatomy, the operability to assess pH and PVR, pH, PVR and RV function, the suitability of transcatheter closure, mitral valve pathology, that's very important to assess in a patient with ASD, pulmonary venous anomalies because it can be associated PA-PVC and anomalous drainage of pulmonary veins, left heart pathologies and other anomalies, and there is a need for additional imaging depending upon the completeness of the echocardiogram. Now, coming to understand the natural history of ASD, one of the important things is pH. Elevated PA pressure frequently occurs in patients with ASD. The prevalence increases with age, but it is not linear. A nice study by Cherini et al. Has shown that the percentage of patients who have ASD from the younger to the older patients remains relatively same, even though the incidence increases with age. And But the incidence of severe PH with high PVR is relatively rare, in the range of 4 to 14%. So what happens to PH after ASD closure? The fate of PVR is after ASD closure is not clearly defined. In general, PVR of more than 10 wood unit per meter square is considered high and not suitable for closure. When I've gone through many of the literature, what has happened is that the units for PVR has been so many different types. But the standard one, the correct one would be wood unit into meter square and not by meter square. Steele et al. On a follow-up of 12 years have shown that patients with PVR of more than 7 wood unit, 40% died in that cohort group. Similarly, most studies have shown that whenever the PVR is more than 15 units, the invariably long-term outcome is not too great. There is significant heterogeneity in data, and sometimes we again find patients who have high pH tend to do well. That is because the etiopathogenesis of PVR is different. Lung biopsy has shown varying anatomy in different samples, and the same patient, when you take samples from different area, the pathology changes, and therefore the prognostic value of lung specimens have not been an important prognostic factor. Finisted ASD closure has some role, because when you leave a small ASD, it acts as a pop-off. And a follow-up study has shown that when patients with PVR who have more than 9 wood units, some patients have improved with time. But the important thing is that with the new vasodilator therapy and drugs that modify pulmonary arterial matrix composition and smooth muscle tone is likely to play an important role, and coming days we would be able to operate patients who are on high pH and high PVR and can alter the natural history of these patients so that the outcomes are better. So this is a paper which looks into sildenafil therapy, and they found that in a subset of patients, PVR actually does come down, but significantly the outcomes can be better and their exercise tolerance improves. So these patients become amenable to surgery. Now the second important thing is arrhythmias with ASDs. Arrhythmias are a natural part of the natural history, and most common is atrial fibrillation and atrial flutter. The onset of atrial fibrillation is important because that is when heart failure begins. And AF as a prevalence increases with age. It is around 15% between 10 to 40 to 60 years and 61% above 60 years. The risk increases with the chamber enlargement associated with mitral valve pathology, tricuspidal regurgitation, and ventricular dysfunction. Most of it is attributable to atrial stretch, and so that any patients who have ASDs in the adult age group would require some form of ablation or a MACE procedure to prevent atrial flutter and fibrillation. So this is a patient with a large ASD with a huge LA clot, which we had to anticoagulate before taking for procedure. The other important thing is mitral regurgitation. Often this is underassessed and not properly categorized. The common causes are mitral valve prolapse, rheumatic, congenital, clefts, caudal rupture, and sometimes a plaque-like lesion which is seen in the AML because of a dysfunctional movement of the septum. Often it's underestimated. MRs are obligatory shunts, in the means that despite high PVR, you may have shunts because the left-right shunt is not dependent on no more on the PVR. It contributes to symptoms like heart failure, PH, and congestive heart failure. This is a paper which came about ASD with MR, which shows that the non-rheumatic MR could be as high as 99% to 22%, and 96% the pathology which is in the AML, and is most commonly at the posteromedial commissure where there is a plaque-like thickening, and this needs to be addressed in patients with ASD, especially secondary ASD with MR. Now let's understand the natural history of ASD closure. What happens to these patients in adults? The gold standard is ASD closure, surgical closure, and it has been there from 1948. Now we have a long follow-up of more than 5 decades. The indication for surgery remains same, a QPQS of more than 2:1, or evidence of RV volume overload on echocardiogram. The current mortality of ASD is 0. Murphy et al. Has shown on a follow-up of 27 to 30 year follow-up in 123 patients, a 30-year survival of 74%. In general, if the ASD is closed below the age of 11, the outcomes are similar to that of adult population. Now we have recent studies which shows that even in the age group of 20 to 24, if the ASD is detected and treated, they have a natural survival similar to the natural population. So the important thing is patients with ASD have to be detected early and treated accordingly. Now what happens to PA pressure? We know that long-term outcome of the PA pressure depends on age and the pre-op PA pressures. The cause of mortality include air embolism, low cardiac output, pulmonary infections, which are very, very rare now. And the good news is that there are no late deaths in survivors with near normal PA pressure. So these patients are treated for life. There is no consensus about the level of PVR which is at above which surgery is not indicated. Ramatul has shown that when the PA pressure is more than PA systolic is more than 60%, outcome is not so good. Similarly, Sternal has also shown that in PVR less than 15 millimeter mercury, outcomes are better. But once more than that, outcomes can be poor. Somerville has shown that some patients with high PVR who are not on pulmonary vascular therapy, they may not do well with ASD closure. But with the availability of now the pulmonary vascular drugs, this thing is no longer applicable. Now coming to ASD device closure, now we have lots of devices before ambulatory, but standard now is the ambulatory device closure. The important thing about this device is a self-centering device. It can be retrievable, it does not produce any fracture, it can be repeated many times, and can be deployed in patients without even rim in the aortic area. So the basic design is a double disc device with a central connecting device. And the thrombosis that is induced is because of a polyester patch which is stitched into the 3 portions of the device. So around 70 to 80% of ASDs can be closed by device closure, and a 10-year follow-up has shown that it is comparable to surgery. The important thing in ASD device closure is that how you select the rims, and the most important rims assessment is the posterior inferior and the IVC rim. So this is the echo showing the rims. This is a 3D echo showing the device closure. Patients is usually discharged overnight and can resume normal activities in 3 to 5 days. Complex ASDs are one which have deficient rims. Multiple ASDs occur in about 6 to 8% and may require multiple devices. And sometimes you need balloon sizing, and you can actually make multiple holes into a single hole to close them. So this is in one patient whom we use multiple devices to close the ASD. Now coming to sinus venous ASDs, usually it goes for surgery, but we have now a new technique of closing sinus venous ASD using a covered stent. This is a paper which I published in 2014 for when we did a sinus venous closure for the first time, where we used a covered stent to reroute the right upper pulmonary vein into the left atrium, simultaneously closing of the ASD. So I'll just show you how this is. This is the superior vena cava while it joins the right atrium, and the posterior wall of SVC is in communication with LA, and this is where the shunt is. And if you put a covered stent, the posterior wall of the covered stent would form the anterior wall of the right upper pulmonary vein, and this would drain into left atrium. If you can demonstrate this by echocardiography, then these patients are suitable for sinus venous ASD closure. The CT pictures. All patients undergo balloon occlusion study. I'll just quickly show you through this. This is the balloon occlusion study in a patient in which the pulmonary vein is obstructed and is not suitable for this procedure. This is where the pulmonary vein is not unobstructed and flows to the left atrium. This again shows the balloon which closes of the ASD, and you can see that the posterior wall is formed by the anterior wall of the balloon and the pulmonary veins are draining normally. Once I see this patient automatically goes for a transcatheter closure. So I have done around 25 patients like this. We use multiple stents. This is a covered stent or an intravascular graft like this. The series of last 5 cases, we use an endograft to close the device, close the sinus venous ASD. It will look like this. The ASD gets closed, and the flow, the small residual flows happens at this edge where it catches the inradial septum. This is how the flow opens through the SVC, and the LA gets closed off here, and the stent covers the portion where the atrial septum is in discontinuous with the upper margin of the SVC. This is how this CT scan shows the posterior wall getting closed off. This is the youngest patient which I've done. These are the percutaneous complications that happen with ASD. To conclude, the rapid changes that is happening in our understanding and management of relatively simple lesions like ASD. The long-term complications of ASD can be prevented if the lesions are detected and treated early in life. Better understanding of the anatomy and imaging techniques allows newer techniques and modifications for the old ones. The new pH modifying medications would enable ASD patients with elevated PVR to be corrected with altering the natural history of these patients. Thank you.
So, any questions, please?
I would like to know whether there is a separate component of right ventricular dysfunction which evolves in AST with no pulmonary hypertension, no left ventricular disease, or
Yes.
no left heart disease. If that exists, what are the indications to look for it, and what is the best test to evaluate in a clinical situation the right ventricular function, ejection fraction, etc., whatever?
Echocardiographically, we can assess the right ventricular function by TAPSE, where the movement of the tricuspid valve we can measure and see whether the RV function is good. Otherwise, we can have MR to assess the RV volume and exactly calculate the RV function as well as the RV cardiac output. So these are the two modalities which we have, which we can accurately assess the RV function.
What about the incidence of arrhythmias which were not pre-existent but after the closure of surgery, unrelated to, after the closure of the defect, unrelated to cannulation or whatever?
See, patients who are more than 40 years, even after ASD closure, there is an incidence up to 5 to 10% of new onset atrial fibrillation flutter on a natural history of these patients.
Is there any correlation with right ventricular dysfunction and incidence of arrhythmia?
I don't have any, I have not read a paper comparing RV function to arrhythmia. But there are lots of papers which shows that atrial stretch and arrhythmias have been related. There's lots of paper on that.
Thank you.
One thing is that closure of ASD has not actually been associated with reduction of atrial arrhythmias in the long term. Therefore, when you follow those patients, they do develop atrial fibrillation.
That is in patients who are less than 40 years, the onset of arrhythmias is similar to general population.
Yeah.
But when it happens after 40 years, they have higher incidence.
Yeah. So one of the things that we are telling is that when you're doing an adult ASD, do a right-sided maze and do it off so that it can probably reduce the risk in their long term, this thing, because the lesions are already placed.
Is right-sided maze a standard recommendation? Or
see, we know that we can do it for Epstein's and things like that. So there is no such thing as standard. Nobody has done this thing, but we are doing right side because we know in the natural history these people are going to have a higher risk than normals. And
thank you. Thank you.
Yeah, thank you, Anil. Just to discuss two cases which happened to be done recently. One is around 27 years old ASD and another is 74-year-old ASD. So 37 years old ASD, not married, was admitted with a hemoglobin of 4 in heart failure for the medicine department. They never diagnosed ASD. So heart failure was corrected and hemoglobin caught up, and subsequently when they did an echo, ASD was there. I took her for an ASD closure, but post-op I had a lot of challenges with severe RV dysfunction and all. I had to long inotop stay and all. Had come back after discharge with a pericardial effusion. That I wanted to know what was the cause. While going there was no PE, came back with PE, at present in the ward with the PE drained. Second case was 74-year-old, systemic hypertension, not on medications, had come for a follow-up. We got a cash studies done. My question is, when to intervene these? Some go for high PA pressure, some do not go at all. Do we intervene or no? Number one. What is the role of LV end diastolic pressure in these cases? In her, we did a catch, it was around 12. How does LV end diastolic pressure, what is the cutoff limits wherein we need to intervene? And suppose these patients have associated coronary artery disease, how does it make it an impact on the RV function post-op?
So I think you've asked not many questions. So let me answer the LVDP first.
Yes.
In especially in a patient, in a subset of patients with LV diastolic dysfunction, when you close ASDs, the LA pressures could high up, and there is a subset of patients who develop pulmonary edema. This is seen in patients with ASD closure also. When you put a device, they develop flash pulmonary edema. And many of the patients after diuretic therapy, they become improved. So transient elevations to LVDP can be handled very well. And this can be handled by diuretic therapy, and these patients do well. So, but in patients, when you select elderly patients with large ASDs, often what we do is that we do a balloon occlusion study to see whether this thing can happen. In that patients, what we do is a fenestrated ASD closure, so that this does not happen and the long-term morbidity is not affected. So personally, whenever I do a patient who is above 60 and his LVDP is high, and I do a balloon occlusion and there is a rise in LA pressure, I do a fenestrated ASD vasculation. I don't do a complete ASD vasculation.
LA pressure high in the sense to what extent you upper limit?
If it is more than 20, I'll do
more than 20.
fenestrated ASD vasculation. The second question is, if there is a patient has coronary artery anomalies, that coronary artery disease, you got to address it. The other question you ask is the ASD in an elderly patient. You know, there is a paper which addresses whether we actually doing good for patients more than 60 years or for ASD surgical closure. That's we don't have actual data for it, but looking back, see the outcomes since the age at survival keeps on increasing. I think there is potential benefit in repairing these patients so that we can improve their outcomes in the longer.
No, elderly patients, I want the opinion of the audience also. Should we intervene or no? Because of what benefit it happens, I don't know.
There are papers from the 80s and 90s where they specifically studied elderly ASDs. Does not improve the quantity of life, but it will only improve the quality of life.
We have no data to tell what happens.
No, there was data in the 90s, and St. Vitus James or something, quite a large paper on ASDs done after 60s. I don't know why everyone says there's no data. There was data available, and in that they showed no survival benefit, but increase in better quantity of life and better, quality of life, better effort tolerance and reduce symptoms.
Can I have one last question, please? And nice talk, enjoyed it. So we were all discussing about RIRV dilatation, long-term effects of arrhythmia and all. In your opinion, what is the ideal age to close an ASD?
See, I will close the ASD very, very early. I would like to close the ASD below 2 years. Reason is very simple. See, when the child is less than 1 year, the total atrial septal length is 15 to 16 millimeters only. But the same child, when it goes to an adult, the total atrial septal length increases to 45 to 55. So the ASD definitely increases in size. So you close the children earlier, you use smaller device.
Yeah, why I ask this question is that I see a lot of cardiologists growing up the children to put in a device, and ideally I think it should be done at 2 years, or even if you look in the latest, the Kirkland says around 2 years. So
I close younger and younger.
Yeah, it's better.
Okay, thank you very much for your presentation. So we'll move on. Now, next is aortic regurgitation from newborns to adolescents by Dr. Baiju S. Dharan.
Very good morning. Thank you, Dr. Jayakumar and team. Nice to see you all, guys. Thank you for this opportunity. I've been asked to talk about aortic regurgitation from neonates to adolescents, which I thought is a very vast topic to cover in 15 minutes. So I thought I will restrict rather to the choice of the procedure, because it's very important to know what to do as much as like how to do it. So I think I need not go into the details of all this, because I see most of experienced surgeons around. We don't have small processes, and whatever we do in children, we have to account for the growth, and it has to stand the test of time. They are going to live more than us. And of course, you know, anticoagulation is problematic in any age group, and you start anticoagulation in younger age group, you expose them to more patient years, so the complications are even higher. If you look at the etiology, like the most of the aortic regurgitation children we see is associated with ASDs, and sadly it's a preventable disease. Many times the cardiologist sits on it till the aortic valve is deformed. Now as years go by, we see less and less of it, happily, because the moment we see a distortion of the aortic valve, even without aortic regurgitation, we go in, and more of unicuspid and bicuspid valves could be associated with subaortic obstruction, and could be maybe with the conotruncal anomalies. We see more and more of them, especially in the postoperative period, post-op arterial sutures, truncas coming back with It's not basically a disease of aortic valve, it's a disease of aortic root, and we need to do something more than just repairing the valve. And of acquired rheumatic is quite rare, but we occasionally see infective endocarditis with severe regurgitation and of course some root involvement. So we got a multiple options, and it also says that none is perfect. So we have aortic valve repair. We can replace the valve with a mechanical valve or by a prosthetic valve, of course, most often with a root enlargement. You have the Ross operation. You have got a you can replace it with a homograft, and of late, Osaki is also coming into practice in children. So now, how do we choose? Whatever we choose, like it has to be feasible anatomically, like you can't do a Ross operation in a pulmonary atresia or a truncus, so it has to be anatomically feasible, it has to suit that particular patient's anatomy, and it has to be fairly simple and reproducible, and should have a very good early outcome. We can't afford to have a very complex procedure with a high early mortality. But the crux is that whatever you do, it should stand the test of time, it should last as long as possible, and it should have a growth potential. With that, we'll just look at the outcome. This particular publication is from Melbourne, where they compared aortic valve repair with the Ross operation in long time. And you have your pointer? And if you look at the survival alone, aortic valve repair tends to do slightly better than Ross in the long term, and even in the short term. But if you look at the reoperations, reoperations are obviously high in the aortic valve repair, and if you look at the reoperation for aortic replacement alone, then obviously the aortic valve repair group goes much down, and Ross is much higher freedom from reoperation in long term just for the aortic valve. Obviously this is skewed because they might need reoperation for the RVOT. This is interesting. When you have got an optimal repair and a suboptimal repair, if you look at the suboptimal repair, okay. There's a pointer walk here, pointer in this. So it just tells you that even if you have a suboptimal repair, in the long term, their survival is almost as same as Ross. Obviously, their reoperation rates are high, but their survival, even with a suboptimal repair, is same as Ross. Hope you will get some message from that. And they also looked at aortic valve repair with and without patch. Obviously, the one with the patch will do much worse. They will have higher reoperations. And look at the Ross operation here. Beautiful. Like you got a 95% freedom from reoperation at 5 years. But mind you, this is a group of aortic stenosis and aortic regurgitation. We all know that Ross does better in aortic stenosis. This may not be entirely true when you consider the cohort of aortic regurgitation alone, but still, Ross has got excellent long-term survival, and freedom from reoperation for the aortic valve is also very good. But when you consider the RVOT as well here, the freedom from reoperation comes down. But replacing an RVOT conduit is not a much deal in this. Now we look at the impact of age. And this is for aortic valve repair, this is a survival, but when you take the neonates alone, there is a big dip early. So there is only an 80% survival early. So it tells you that, like, if you are forced to operate on a neonate or an infant, your outcome is going to be bad. But once you come over that hazard phase, you can see both the plots are parallel. So the early mortality is there, but things are, and just to tell you about the mortality, comparing the mortality of Ross and aortic valve repair in neonates and children, it's entirely different. It's two different ball games. And if you look at the Ross operation itself, you can see the infants will have a higher early mortality. But if you look at the reoperations, it's interesting to see that infants will require less reoperations for the aortic root rather than the adolescents in the long term. And it is reversed when you consider the RVOT. If you do an infant, you will need more reoperations for RVOT, but not for the aortic valve. And this is when you can't repair and when you want to substitute, what to substitute with. This is a practice pattern from US published a couple of years back. And as you see, the younger children, most of them will get rose, whether male, this is male and this is female, whether male or female. A small proportion will get mechanical valve, and then bioprosthetic and homograft and a smaller. But if you look in the adolescents, lesser number will get rose, and maybe more females will get rose, and males will get more mechanical valves and than females, obviously, with the idea of avoiding, females who would like to avoid anticoagulation, and of course, girls will get more of bioprosthetic and homographs for obvious reasons. And if you look at the reoperation rate with bioprosthetic, this is not surprising. But what is surprising is that even if you put a mechanical valve, you have got a 56% reoperation rate. And bioprosthetic and homographs obviously is very low, very, very high reoperation rate. So which processes to put? This is from Boston, and in their study they have shown that Onyx performs much better than other valves. And there is no data on Chitra valve. We have done a few, but our numbers are not enough. Maybe we could collaborate with all of you who put Chitra valves in children. And luckily, touch wood, I didn't have an opportunity to reoperate on any Chitra valve, even the smallest valve we have put so far. Very similar results from Melbourne as well. Onyx tends to do much better than compared to the other valves. The impact of valve size, obviously, we put a larger valve, their outcome is much better, and it's drastically different if you put a valve of 19 and lower or bigger than 19. And this is the hot topic. Osaki in children, this is from Boston, Christopher Bates' experience, and single valve replacement, single leaflet replacement. They had freedom from more than moderate AR at 76% at 2 years. Too early to say, but still they are not doing as well as what we would expect them to do. And again from Boston, the Osaki repair, and you see the AR slowly progresses in time. And if you look at this scatter plot, like there are quite a few patients that has gone very drastically up. And there is not much difference between a single leaflet and Osaki. For infective endocarditis, we mostly use aortic homographs. And there is a big early dip in the early survival. But this is surprising because probably the worst ones got a ROS. got a homograft, and the reoperation rates are much higher for the homograft. These are a few techniques which I thought there will be a lot of youngsters. I think I can skip. The one question is this: should we do an annuloplasty or not? The problem is that you do an annuloplasty, you fix the annulus, and when they come back, you struggle to put in a valve. Two days back, I operated a child whom I did a VSD closure with aortic valve repair in 2007, 17 years back. And luckily, I didn't do an annuloplasty. His annulus grown. And what has happened to the trustless repair is that both the commissions are fused, and you fix one commission, the other two commissions grow. And probably it is repairable, but then the family couldn't afford another, so I replaced. I could put a 29 valve just because I didn't do an annuloplasty. Had I done an annuloplasty, I operated him as 2 years. Had I done an annuloplasty to 13 or 14, I would have struggled with him. So I think you have to take it with what you need to think about it again. Leaflet extension, again the problem is the material what you choose. We have not found an ideal material. Whatever you use, you're bound to have a problem with the material. And this is one of our bicuspid valves we extended with. This is a follow-up. I've chosen only up to 2015 so that we have got a median follow-up of around 10 years. we had 19 of moderate aortic regurgitation, 32 of severe aortic regurgitation. Most of them we could get down to mild or moderate, and one severe patient had a moderate regurgitation or slightly more than moderate regurgitation at discharge, and we replaced in the same. And what happens is that you can see there is progression of the AR in quite a few patients. Not too many in this particular series. Like there is one here, trivial became moderate and follow-up. A few with one with a mild became severe. But luckily for us, most of them remain more or less okay. Again, I'll skip all that. The complex things, you all know how to repair a truncal and postnatal. So I'll just conclude. I would rather to reiterate that aortic valve repair is a procedure of choice across the age groups, and it should be offered whenever it's technically and anatomically feasible. Rose operation is still the gold standard. When you can't repair, Rose is still the gold standard. And mechanical valve, of course, with or without a root enlargement, is reasonable in boys. And of course, I'm not advertising for any company, but I think Onyx tends to do better and make sure that you put a valve bigger than 19 mm. Bioprosthetic valve results are bad. Should be considered only when you can't give an anticoagulation, and homografts are best reserved for endocarditis with root involvement. But our results are not as bad as what we've seen in literature, but still I think we still reserve it for endocarditis or when we don't have options. Thank you so much. And credits for this collage goes to the next speaker.
How much of the post-tetralogy or post-Fontan AR is coming now for you, because you've been doing quite a lot?
Yes, post-tetralogy, like we find a few, but to be honest, there was not an opportunity to reoperate so far. But we have seen post-arterial, especially TOCB, post-arterial switch coming back. And having said that, there is another one post-tetralogy patient waiting for aortic valve replacement and scheduled for tomorrow. But that's a different thing. Like this child had a bicuspid aortic valve tetralogy repaired in 2002, and he had an infective endocarditis. And he developed severe AR, and unfortunately he went to renal shutdown with antibiotics. So he is scheduled for next week. So, but otherwise, and again, Fontan is, yes, I've done one who had a Kawashima and came back with a severe aortic regurgitation. And basically it's an aortic root disease. That particular patient, what I did is that we did a aortic annuloplasty, external annuloplasty with supraaortic, supracommissural ascending aortic replacement.
I'm just expecting in the future we will be having more such cases. So are we started getting those cases with
Yes. There are a couple of patients, one done elsewhere and one done by myself. Both are TOSI beings, and they have more than moderate aortic regurgitation.
So one more question. In the infant, what's your personal preference now, Osaki versus thing, or are you not happy?
The crux is the leaflet material what you use. And we have been doing using aortic pericardium for replacing aortic valve, at least in parts. And I'm not happy, like our results are not that good. We had to reoperate. The crux is what you use. And the crux, can I complete? The crux is what we use. And if you look at the Boston series, 50% of the patients received bovine pericardium. And my take is that it's not going to be any better than a stainless prosthesis in long term, when you use a bovine pericardium.
Yeah, I think bovine pericardium is just too thick for a kid and for a valve. I tried it and I felt
we are still searching for an ideal material, and I just found a recent publication where they used the aortic wall as the replacement material. Then I was thinking, then pulmonary wall will be a better material.
Actually, what I've done is to tricuspidize. I just told yesterday is I've taken single leaflet there and tricuspidize the bicuspid valve, and then done a Ozaki on the pulmonary side, so that hopefully that gets tolerated.
The problem with single leaflet, if you know, you got two different materials in the leaflet, and that tensile, their biological behavior is less, I mean, much different.
That's why I put it on the pulmonary side. I took the pulmonary leaflet and tricuspidized the aortic. No, I took one leaflet, I made the bicuspid valve, shifted the commissure, made it and put this and made it tricuspid. I made the bicuspid valve tricuspid by shifting the commissure, and then took the pulmonary valve to fill that space, and a pulmonary leaflet, and did only a single leaflet on that. I've done two now.
Okay, so we have to move on. Thank you so much, sir. The next presentation will be the last presentation of the session, because I think Dr. Debashish Das had to catch a flight or something. So the next topic is biventricular conversion after initial cavopulmonary shunt, challenges in decision and techniques.
Morning, everybody. First of all, thanks to the organizers for the opportunity, wonderful hospitality, content, Dr. Jayakumar, Dr. Vinita and team. And thanks to my co-speakers for preponing my talk. So I'm going to take you away from valves a little bit, and what we are going to talk here, you've got two very important talks on Fontan after this. So you will know as to why Fontan is not probably a very ideal circulation in the long run. With that background, I think we are just talking about some patients who are partially already on the univentricular pathway come to us, and then we see that the heart has grown, the morphology has changed, and is there a case to now put them on a biventricular pathway? But whenever we are faced with such a situation, I think it is not a very simple decision to make. Our goal here is, what we have to weigh is, it is a better long-term outcome procedure, but at a risk of a more complex immediate surgical procedure. So again, it is a milieu where you need to have a shared decision making with the parents. You need to see what is the risk appetite, you need to see the experience of the surgical team, and then take a very sane decision. This I won't dwell upon because we have talks on Fontan. You know that it is not an ideal circulation. In the long run, they'll develop complications like protein-losing enteropathy, plastic bronchitis, thromboembolism, and a host of other complications. However, the key here is to strike a balance between the risk of a very complex biventricular repair vis-a-vis the long-term complications of Fontan. Some of them do end up on the wait list of transplants because ultimately this circulation starts failing. So with that idea, this is one of the initial papers from Ed Bowe's group where they converted some of the already done glen into a biventricular or a 1.5. 1.5 meaning that they would leave the glen intact and just convert it into a biventricular with the IVC blood going. And the most common subsets that they dealt with, which is very common in all the papers, is double outlet right ventricular VSD-PS. Then some of them will be DTGA VSD-PS. These are the two commonest anatomical subsets that we would deal with. And some of them are more complex than that. And we've got a hoard of evidence across various groups now that it is possible. Of course, this is a paper from Boston, and they have been very aggressive with it. They've been converting hypoplastic left hearts onto a biventricular pathway after doing multiple procedures. We had a very interesting session in the Bhubaneswar conference where Dr. Sitaram Emani was there, who was leading that biventricular conversion program in Boston. So what I'm saying is, it is possible. But when will we actually do it? That decision is the key. Because this is another concept where we were trying to do something like a ventricular switch, a Cleveland isolated one surgeon experience. And a very complex procedure was basically designed to do a switch at a ventricular level to put them on a relative hypoplast of the left side. And again, this is where we need to draw the line, because they have a very high rate of reinterventions, very high mortality, morbidity. And again, this is probably one of the, warning that, it is not that every heart can be converted onto this pathway. So now we are dealing with a situation where a cavopulmonary shunt or a glen has been done already, and now we need to decide as to whether we are going to convert it into a biventricular completely. We would undo the glen also and complete it into either a 1.5 or a 2 ventricular repair. The commonest subset will be double outlet right ventricle with a VSDPS, DTG VSDPS. You will have various other codes of pathologies like tetralogy AV canals in an abnormal situs. The volumes of the RV, LV might not have been appropriate when they did the glen or when you yourself might have done the glen. So again, it is a redo situation, so the same rules apply. We need to be safe. So, you'll probably do a CT chest, lateral chest X-ray to make the re-entry as safe as possible. A previous operation note, especially when the patient has been operated elsewhere, is one of the key documents we should have with the usual safeguards of having your options for peripheral bypass, blood in the OR, safe re-entry. Because when you're embarking on a complex procedure, if your re-entry and the initial dissection is not safe, I think the whole plan starts falling apart. Your anesthesia team, your perfusion team, everybody needs to be on board with what you're going to do. And the basic criterion is we need to have 2 good ventricles. The location of the VSD is basically which is the main key decision-making anatomical entity, whether you need to enlarge it, whether you need to use a contoured patch in the sense of an interventricular tunnel repair, what is the great vessels relationship, and we have got a host of operations to choose from, and which one would we choose. So from these list of operations, I think it will depend upon how remote is the VSD, so how is going to be your LV to aorta pathway is going to be how long, how convoluted. Do you need a ventricle? Do you need the VSD to be enlarged to have an unobstructed LVOT? Is the volume of the RV going to be compromised when you make that LVOT? And is there any significant straddling of the AV valve which precludes this? Based on these points, you have a host of options of doing a Rastelli, Rev, Bex-Nikaido, root translocations, but then you need to individualize it to that particular patient, and that is where imaging plays a role. Of course, echocardiogram is the cornerstone. So as surgeons, we should be integral part of that echo assessment with our cardiologists to know as to how is your future LVOT going to look, whether you're compromising on the volumes of RV when you route that. Another very important imaging tool is the CT scan, along with a 3D reconstruction. Of late, we have used very extensively this. So I'm not advocating printing these hearts, but a 3D reconstruction where you can actually walk inside the heart, look at the future potential outflow tracks, gives you a fair amount of idea as to how difficult the routing is going to be. And cardiac MRI, we haven't used it, but people have used this also as an imaging modality. In very rare circumstances, you can actually get the heart printed, because this has been used. So this is a paper from Mumbai, one of the centers, where this is a list of 5 very complex double outlet right ventricles, 4 of them actually were converted into a biventricular based on a 3D printed model. So even if you don't print it, a 3D imagination of your future outflow tracks after a routing is what is possible if we use either a 3D printing technology or even if just a reconstruction technology which you can use it to your advantage. This is another paper from China with more than 15 patients. They actually were able to convert it into a biventricular conversion based on using of this imaging modality. So we had a patient who was banded with a tetralogy AV canal, some degree of straddling. So we actually sent those images to Amrita Kochi with Dr. Mahesh's 3D lab. And he actually showed me, so this is me wearing that headset, I could actually cut into the heart, get into the, see what is the future LV outflow will be looking like, whether we'll be able to sort of do it. And based on that, we actually repaired it. So imaging plays a major role in the decision making. It is not always needed to print it, but if you need to print it, it is available. So these operations are complex. This is one of the Nikaido after a cavopulmonary shunt. So it looks like a fairly extensive dissection. After that, we need to take off the aortic root, cut the conal septum. You can see the VSD now has been closed after the aortic root has been translocated. The LVOT becomes completely straight, and then we reconstruct the RVOT. But one important factor when we are converting this is your SVC reconstruction. See, that is a venous structure. It is the last in your list of complexity, but that will also have a major impact on how the patient behaves. So you should have a clear idea of how you would reconstruct the SVC to have an unobstructed inflow into the RA. This is another patient who had a BT shunt as the initial procedure. There were not much adhesions, so it looked like a primary operation. And we call it modified Nikaido because we harvested the coronaries and used a Quantegra to convert. This is a double outlet right ventricle which was converted into after a Glenn was converted. Most of these operations were done elsewhere in our experience. And as I said, your SVC reconstruction option, whichever you use, whether you use a complete pericardial tube, you will have to use some extra material because by the time the SVC has been anastomosed to the pulmonary artery in a Glenn fashion, it loses a significant amount of length that can actually stretch it. So what we use is one of the methods described by the Boston unit where the posterior wall, so there is a wall of RA which we upturn, use that as the posterior wall and put an anterior pericardial tube. So whichever strategy, so there are various case scenarios where you will have to do it. You can see how short the SVC becomes after a Glenn for a few years, and then there is not much length to play with to actually make it drain unobstructedly into the right atrium. So that is why we would undo that. We'll patch up the pulmonary artery where the Glenn is there, then use the RA flap as the posterior wall, and then put an anterior bovine pericardium or even a native pericardium if it is of good quality to reconstruct the SVC. It is not a very unimportant part of the operation. It does take time, so you need to keep in your mental plan that this is also something that you need to do. So your entire operation should be in your mind when you plan this because there is so much to do that intraoperatively you should not be taking these decisions. This is clear from beforehand. It will be easy to execute. Postoperative transesophageal echo just to assess your outflow tracts is of paramount importance. However, as I said, we should not be ruling out completion Fontan as an option because this was an eye-opening paper from Melbourne group where they compared DTGA VSD patients, 129 patients, out of which 29 were Fontan, 100 biventricular repairs. And the Fontan patients did not do as bad. There were more re-interventions in the biventricular group, and they showed that Fontan patients had a reasonable quality of life, low row intervention rates, so that also remains an option. And it all depends on the comfort of conversion of the surgical team, whether you want to embark on this pathway or not. So these are some 9 patients which we did in last 3-4 years, and most of them are double outlet right ventricular PS operated elsewhere with a Glenn. Few of them are DTGA VSD PS where we used a host of operations. Most of them are interventricular tunnel repairs. 2 of them are Nikaidos. 1 of them is a REV, and most of them did very well. 1 patient we lose to a late stroke. So to conclude, ladies and gentlemen, it is a complex decision to take. However, biventricular conversion after a cavopulmonary shunt is a situation that all congenital surgeons we face. The form of surgery will have to be individualized to that particular anatomy of the patient. A safe sternal re-entry, a careful planning is the key to execute a plan properly. SVC reconstruction is a small part of the operation, but do have that in your armamentarium clear in your mind before you enter. And again, it is a shared decision making between the clinical team, the parents, the risk appetite, and what all can we actually offer. So the key here is to strike a balance of the risk of a complex biventricular procedure vis-a-vis the long-term complications of Fontan. So we need to choose wisely. Thank you for your attention. I can't hear you.
Hello. So we know that Glenn and Fontan at least does relatively good in the short term. So do you, if you have a patient, do you let them go for a univentricular pathway for some time before you go for biventricular, or you just straight away go for biventricular?
So most of these patients would actually come to you where they have been on a Glenn for a few years already. So they are either sort of there in their early adolescence where we have seen most. They might have been operated most likely elsewhere because with your own patients you will probably have a plan already and you will follow them up more rigorously. However, these are all patients who are above 10 kg of weight. So below 10 kg to do a very complex routing will probably have its own set of challenges. So we have not embarked on them earlier than when they are 10 kgs and beyond is when we would advocate. So they are almost 1 year, 1.5 years with a cavopulmonary shunt is that time. Some of them are on BT shunts also. They are of a lesser duration of 6 to 8 months.
You give them for a ventilation for a longer period of time because Glenn unloads the heart also.
Yes, you can. So that is why the assessment is as to whether you will just wait, whether the patient is desaturating to an extent that you need to go in early and you think biventricular repair is not possible, then maybe you complete the Fontan and let him be on that pathway, or just wait and let him gain some more weight. And so it is again a very individual decision to that particular patient based on how his quality of life, his saturation, exercise tolerance with a cavopulmonary shunt at that stage is.
My question, if you are doing Fontan with fenestration, will that help in a future biventricular conversion by keeping the diastolic function intact? Do you?
I haven't come across any specific impact of fenestration on potential for biventricular conversion, so I really don't have thoughts on that. I don't think anybody has looked into that from that aspect.
Debashish, nice talk. One question.
Thank you.
How important is it to take down a gland? Because our philosophy, like there have been a lot of patients who have been palliated with a BDG in our setup, because the beauty of BDG is that interstage mortality is very less, and in the pre-homograph data. My question is that how important is it to take down a gland during a biventricular conversion? Because leaving a gland will give you, especially when you use a conduit, you give you a little more time to wait for a conduit replacement. So what is the take on that?
So again, it depends. So we are dealing with a situation where we can do a 1.5 ventricle or make it complete 2 ventricle repair. So I think the key thing is, one, if there is no distortion of the branch pulmonary arteries after a glen, if the length of the SVC is okay, and if your actual routing procedure is of a magnitude that you can execute it on a fairly organized fashion, that you have the time to reconstruct the SVC, I think we should convert it into a biventricular conversion. Once we open up, the length of the SVC is the key as to what form of reconstruction would it need. But it is very important to actually assess it post-op also by your pressure monitoring line, that whether there is any gradient in the SVC to RA, because sometimes that might actually have an impact on even your immediate outcomes. So it is not a small thing, but whenever we think that it is too complex to handle it, just leaving it alone and doing the rest of it is probably fine.
Yeah, why I asked that, our philosophy is basically to leave it as a glen. And I know that there are studies which show that their exercise capacity in 1.5 ventricle is slightly less than a biventricular, but it gives you an advantage waiting for the conduit.
Absolutely.
And obviously these children tolerated a glen only because the pulmonary vascular resistance is low. Yes. And when you put an antigrade flow, usually in our experience it's less than 20.
They do just
they do tolerate.
No, that is a very balanced decision. Thank you.
This is just an academic question.
Sir.
When you say a good right ventricle and good left ventricle, the entity of pulmonary atresia with intact ventricular septum, which had a previous shunt and outflow enlargement with a patch, where the right ventricle is unlikely to be fully developed. The outflow tract may not be there. There may be sinusoids and a dependent coronary circulation with coronary stenosis, or non-dependent coronary circulation with no coronary stenosis. So is it the final thing is a 1.5 ventricle, or is there any space for full biventricular repair in this case? And also when you talk about left ventricle, the morphology of the left ventricle, that's a systemic ventricle, has it had to be morphological left ventricle or indeterminate or whatever?
Yes, sir. So it is very important that your systemic ventricle in future should be having the LV morphology to give you that advantage. Otherwise the whole idea is not. Second thing is intact septum with pulmonary atresia and like as coronary RV dependent coronary circulation, that is I think one subset in which we should just not embark on this, because we might land up on more increasing complications rather than trying to convert those subsets. If we have demonstrated that this is an RV dependent coronary circulation, I don't think we should decompress and try and convert it, because we may land up in problem. However, the morphology of the future systemic ventricle is the key to a long-term outcome. So that should be paid enough importance to, sir.
Thank you.
Thank you.
Thank you, sir. We'll go on to the next talk. I'll call upon Dr. Thomas to give a talk on post-ICR pulmonary regurgitation tetralogy of fellow. I think there is a little change in the order. I would invite Dr. Sachin Talwar to talk on evolution in type of Fontan circuits, advantages and disadvantages.
So at the outset, I thank the organizers for inviting me for this conference, and I assure that all the videos that I have made are with full permission of the patient. Now this is a picture which I love. The smile of Mona Lisa and Fontan. Now Mona Lisa, nobody has been able to interpret the smile yet, and similarly the Fontan circulation. We are trying to learn, and we are trying to learn. Nobody knows what is the best. So we know that it's the common destination pathway for all patients who have a functional single ventricle, and the loss of the pulmonary ventricle is the essence of the Fontan circulation. So why do we need, I will not go to the hemodynamics, I will simply talk of what is the need for evolving the Fontan circuits. First, to optimize the hemodynamics. Second, because there is no ideal circuit. Third, to have a better early and long-term survival, to have the decreased early and late effusions, because these are the common problems, to have the less early and the late arrhythmias, and to have the less protein losing enteropathy, and to have the less early and the late Fontan failure. The last five are the most common problems that occur with this unphysiological circuit. So if you see all of our problems in any medical science, they are focused on improving the patient outcomes, and they are dependent on a large number of factors. Your own expertise, your patient values, your available evidence, and the surgeon confidence and capability. So if you see the evolution timelines on Earth, the fish have lived for 500 million years, reptiles for 300 million years, the mammals for 200 million years, the birds for 150 million years. And you see that in the fishes, the heart into the gills into the muscle. In a two-ventricle heart, the lungs are the ones which propel the blood to a single ventricle, not into the systemic ventricle, the somatic organs, the portal circulation, and then the liver. Therefore, the absence of an in-series pulmonary circulation and systemic circulation is the essence of the systemic circulation. Hence it is bound to fail, whatever you modify. So if you see in 1971, the report came of the surgical repair of the tricuspid atresia by Fontan, who is known as the father of the Fontan circuit, in which he used two homographs, and one homograph was connected to the right atrium to the pulmonary artery. The second was used from the inferior vena cava to the pulmonary artery, and a large atrial septal defect was made, and a classic Glenn stent was made. The problems that were soon realized was the development of the atriovenous malformations in the right lung, and then the problems with the homograft. Then Kreutzer modified this operation, in which he simply dispensed with a homograft between the inferior vena cava to the right pulmonary artery, and he went into a homograft to the right atrium to the pulmonary artery. And there's always been an open fight between Fontan and Kreutzer about who has done the first Fontan operation. We know it's a matter of debate, but it was a simplified version in which the homograft was placed posterior, and it is said that it produced the less compression. And then came the atriopulmonary connection, which was a combination of the two, and the atria were directly anastomosed to the pulmonary arteries, and that was a compromise that a homograft was not used, and the right atrium was used as a pump and broadened the scope, so you could put it into the more wide number of patients. You did not require a homograft. But there was no beneficial effect because the atrium is not a pump. So you could not say that it is more beneficial, and because the atrium is more distensible, there is increased risk of arrhythmia. So then what happened was the Bjork, he used his different modification in which he used the right atrium to right ventricular anastomosis to prevent the compression of the right atrium to right ventricular anastomosis. So there was a short circuit anastomosis between the right atrium and the right ventricle, so that this circuit could not be compressed, but still there were further modifications in the Bjork in which he wanted to prevent the pulmonary venous obstruction. So therefore he anastomosed the right atrium to the ventricle and he closed the atrial septal defect. Later on, the important Fontan which we still do is the lateral tunnel Fontan, which was proposed by the Mark Delival from Great Ormond Street Hospital for sick children, and this is one of the modifications which many of us still use today, and this was based on the hemodynamic studies, and the advantages were then there was a streamlined flow, a direct shot from the IVC to the pulmonary artery. There were less arrhythmias, there was less atrial thrombus formation, there was no separation of the atria and closure of the AV valve was required this particular time of the operation. The disadvantage was obviously that the autologous atrial septal flap was required for this, and hence the complications of the arrhythmias occurred in the long term. So now the very, very important thing which came up was the fenestration of the patch. Because the Fontan had the systemic venous pressure which was very high, the fenestration was designed to, from the Boston Children's Hospital as a pop-off. So when a fenestration was designed as a pop-off between the systemic venous baffle to the pulmonary venous baffle, it was found that this fenestration acts as temporary worsening of the hemodynamics support and the venous pressures were reduced. So this is a small clip which demonstrates my own technique of performing a fenestration. A large patch is taken. Now it is very important to see that this fenestration is placed at the lower end of the patch, because now what we are realizing is that the cardiologists need to go many times to go inside and do a radiofrequency ablation on the left side of the heart. So if you have the fenestration on the low side of the patch, then the intervention can easily be done. And once you put a patch and direct the inferior vena cava towards the superior vena cava end, you can just wedge the Gore-Tex patch between two layers of the atriotomy, and thus you reduce the size of the atrium while you are taking the bites into the patch and the fenestration in the lower end. The blood exits from the upper end. So this is the modification of the lateral tunnel that was proposed by Mark Deliver. Then came in the 90s the concept of the extracardiac Fontan that was produced from Italy by Carlo Marcelletti, and that has revolutionized the Fontan without the aortic cross clamp. And this can also be performed without the cardiopulmonary bypass, without clamping the aorta, without delivering the cardioplegia. The inferior vena cava can be anastomosed to the right pulmonary artery by a graft, and a superior vena cava to pulmonary artery anastomosis can done. So again you have a straight shot of blood which is going towards the pulmonary artery, and then a straight shot of blood which is coming from the superior caval vein to the pulmonary artery, and that is reducing the energy loss. And also because the atrium is bypassed, it is not subjected to the high pressures. There are no atrial arrhythmias, there are no atrial suture lines. You can do it without the aortic cross clamping. You can do it off pump bypass, and you can do it even in 10 minutes or over, and even in the absence of the systemic venous anomalies. However, it requires the prosthetic material. There is a risk of the thrombosis of the tunnel, risk of the obstruction. It has no growth potential, and it's difficult to reoperate and to take down. Then I came up with a completely autologous Fontan in a 16-year-old girl to avoid the anticoagulation, and in which the main pulmonary artery was mobilized, the inferior vena cava was mobilized, and this operation was done completely without cardiopulmonary bypass. Now this is a fenestration which has been made in the conduit, and this is anastomose between the inferior vena cava to the right atrium, and was done completely off bypass. Then Fontan, Vargas and Jonas came up with an operation known as intra-extra Fontan. Now, because many patients were having the failure of the lateral tunnel Fontan and the extracardiac Fontan, you could simply put a conduit inside the right atrium, and you could simply take out that conduit in the case of an emergency and still be able to provide a straight shot into the pulmonary artery, and also produce a fenestration that is very reliable. So just take a conduit, fenestrate it at the lower end, suture it around the lower end of the IVC, get it out of the atrium, and put it in the right pulmonary artery. So this is called the intra-extra Fontan. Your intra-atrial suture lines are also less. There is a less incidence of arrhythmias. Now came the Australian technique, in which what you do is you just simply take a conduit, make a small fenestration, and at the divided end of the IVC on the aortic cross clamp, you just suture the atrial cuff around it, and the fenestration is very reliable in these patients. So this works very well in this substrate. The other came is the concept of the two stages of the Fontan by Marshall Jacobs, in which after a prior glen, the Fontan is completed, and this has always been a subject of much debate about why should you stage a Fontan. So we always know that the arrhythmias are a common problem of the Fontan, and the conversion of the atriopulmonary Fontan to the lateral tunnel Fontan as a MACE procedure is also become common these days. The off-pump Fontan, which I have a large experience with, more than 500 now, is something which has now radically changed the outcomes in these patients. I'm sorry we do not have time for showing this operation, otherwise I would have shown my detailed technique of performing this operation, and there is a landmark paper which we published, a randomized trial, in which we showed that there are superior outcomes, and a detailed technique has been published in the IJCT and also in a 14-year-old girl, in which we did a completely autologous TCPC on a beating heart, which eliminated the need for entire anticoagulation. Here you can see how the extracardiac Fontan has improved the outcome in more than 400 patients, and how the survival has gradually improved. Now, I would encourage the residents to read this paper, which will give a lot of insights on how the Fontan procedure has evolved on this, the physics and the engineering aspects of the Fontan. Circulation, last but not the least, is a very, very important paper on where we are after 50 years of the Fontan operation. It gives a lot of insights into this operation. So, the Fontan operation, past, now, and future. So, in the past, it was the atriopulmonary connection with a prior glen. Now, it is the extracardiac cavopulmonary connection, and it is now going to the Fontan conversion for the failed Fontan. We are coming up with the pumps, you are coming off the Fontans with the autologous. Fontan, the change in the surgical technique may reduce the attrition. However, we still need the detailed assessment for conversion of the failing Fontans to biventricular conversion, which Dr. Devashish was talking about. And thank you very much for your kind attention.
One is, you say when you do this Fontan extracardiac conduit without cardiopulmonary bypass, when you do the extracardiac conduit without cardiopulmonary bypass, does it cause a little bit of post-operative instability more than in patients who have had on cardiopulmonary bypass? Because you handle so much and without bypass, chances of ventricular dysfunction in the immediate post-operative period is likely to happen. So have you come across that?
I was expecting that question. The problem will occur if you dislocate the heart too much. So something what I found very useful is cut both the pleura down to the frontal nerve and then put a stay suture at the crux of the heart. Now once you do so, using the principles of the off-pump CABG, you are just able to dislocate the heart into the opposite pleural cavity and then go slowly, and you do not have advance. In fact, 95% of these patients do not require aerotrops. And I used to try extubating these patients on the operating table, but now many times, the pressure from the anesthesiologist, the pressure from the second case, we take them to the ICU and extubate. But I found that the requirement of inotrops in these patients was significantly less. In fact, the paper which was published in the World Journal of Pediatrics was showing that the incidence of effusions was very less, and the inotropic score in these patients was very less, and that indicates that the dysfunction was less. The only caveat here is that you need to manipulate the heart gradually, rather than just picking it up and trying to put it into and retracting it too much. Just put a small suture, put it in the pleura, let it wait there, and then go ahead.
And the second question is, this is my observation. When you see follow-up patients after TCPC, many a times parents, and we have also seen that the children don't grow tall. Have you seen that?
They don't
grow in height. That's a very big worry that parents keep asking is, why is he not growing very much?
Tall means the height of the patient,
in
right?
terms of height, yes.
I wish my parents were tall, I could grow taller.
No, it's
so
not.
I think the being taller or being, attaining a particular height has got many features other than the operation per se. Maybe a genetic factor, lot of factors. Because I don't think that is related to the operation per se. It will relate to many, many more factors.
Since the topic was history of an evolution of Fontan, I wanted to add one or 2 points. That I was one of the surgical residents in the 80s with Mark de Laval. So I have seen few of the crisis things. We have seen that. The earliest straightforward Fontan was done for tricuspid atresia.
Yes, exactly.
And those days the problem was the patient returned with a PO2 of 100 or 110, 40% oxygen. In about 3 hours, it dropped to 60 or 70 PO2 or 50, and the oxygen percentage going up. Patient leaking all over the place. Peritoneum is full of ascitic fluid, going on peritoneal dialysis for 1 full day or more, replacing it with fresh frozen plasma. This problem was solved after the modified ultrafiltration was started in 86, again by de Laval. And the other thing was the coronary sinus was meant not to be on the right systemic venous pathway, because some pressure rise was supposed to obstruct the coronary sinus and cause cardiac edema. So this was a thought in many of the intracardiac procedures done those days.
That's a very good point. In fact, when I was trying to make this talk, and my primary aim was not to confuse the residents and the younger audience. So Fontan initially came up as a subset for those patients who had the hypoplasia of the right ventricle because of the tricuspid trade. And when you talk of the evolution of a procedure, then you talk of limiting yourself to a particular subset. Because once you talk of the variable subsets, your discussion can become unmanageable. And these days you have the patients with abnormalities of the situs, juxtaposed appendages, and so many things, the equivocable juxtaposition, and there have been modifications of all types. So if we had discussion of that, I think it would take the full day. So the simplest way to describe the evolution is to stick to a uniform substrate. If you talk of the patients in the US, you're dealing with the patients with hypoplastic left heart, which is a totally different substrate. Here we're talking about the DOR with unrootable VSD and tracheal, which is a simpler substrate. So it makes more sense to discuss those patients. Having said that, confine yourself to tricuspid trade and all the landmarks will come in one go.
Thank you.
Okay, thank you very much. So we move on to the next topic. Post-ICR pulmonary regurgitation in tetralogy of Fallot by Dr. Thomas Matthew.
For lack of time, thank you for the organizers, for inviting me to this talk. Actually, it's a very to have a talk here at KUMARAKOM is a very pleasant situation for me, because during the time of COVID, when the whole world was reeling under the lockdown, I was actually rowing on a canoe on these lakes. So it's I thank the organizers for inviting me for this talk, which is pulmonary incompetence after TOF repair. So even though I am expected to talk on chronic PR, I'll be putting in a few slides on acute PR too. Now, you know that PR is an inevitable part of tetralogy repair, and there's not a way to avoid it, but you should be careful in some of the few subsets like small pulmonary annulus, in situations where you face high pulmonary venous return, arterial return, and in situations where other residual PA distortions. So one of the key things that will help you during the tetralogy repair is when you take the RV-LV pressure, just have a note of your EDP also. A higher EDP indicates a larger quantum of PR. You know, severe PR is a huge subset. It can be the one that raises the EDP and the one that doesn't raise the EDP. So if you see an elevated RV-EDP at the end of ICR, you probably will face more difficulty in the ICU. So there are several ways to tide over this by temporizing using monocusps of various designs. But you should know that most of them are of temporary use, and most of them don't last more than 6 months. So the key to acute management of acute PR is ICU management in terms of ventilatory management and fluid management. So always remember that the RV's afterload is the pulmonary vascular resistance, and always try to lower the pulmonary vascular resistance as much as possible during the post ICR period. You know that the easy way to achieve that is to make sure your ventilatory parameters, your peak airway pressures are less than 15, your mean pressures are a direct reflection of your PVR. So keep it around 10, adjust the IE ratios, and since it's a leaking valve, make sure you have adequate heart rate to maintain the cardiac output. Now, a common misconception that I wanted to address is fluid management in ICR. It's a common terminology, saying to say that, fill the fallow. Does it mean that you overfill the patients after fallow repair? No, you don't overfill the patients. It just means that to achieve euvolemia in a patient after ICR, you will probably have to maintain a higher CVP. That's because your RV-EDP is higher. So don't take into the misconception that after TOF repair you need to overfill the patient, and that's the only way to maintain cardiac output. In fact, most of these cases you should be diuresing after extubation. So the best way to avoid PR, of course, is to prevent it. And after a series of tetralogy repair, once you've crossed 100 cases, you should look into your things and see if you have got at least a 50% rate of annulus preservation. If you're not preserving that much, that probably you're producing too much of, relying too much on the transannular patch. So once the TOF is repaired, you need to follow up these TOF repairs. So to the typical question my patients ask me, am I cured after TOF repair? I always say no, you always have a repaired heart but not a normal one. So if you take 100 patients that you've operated, every 2 years one of your patients after tetralogy repair is going to die. And out of 100 patients, 2 patients are going to require a reintervention. Now this is a linearized rate that has been derived from a 30 years follow-up. But if you look at the way the mortality happens, it's divided into 2 phases, the early phase and the late phase. The early phase lasts around 4 to 5 years, and the late phase starts around 15 to 20 years. So, and the reasons for these are varying. If you look at this grid, you'll know that each phase you have different reasons for mortality and reintervention. So the 3 pillars of follow-up of TOF are echo, ECG, and MRI. Echo is, of course, there are detailed plans like this, but then I don't know how much it's practical in our country. So echo is the cornerstone for follow-up, and adding a lot of new imaging protocols like speckle tracking can improve your benefit of echo. Another important thing that is understated is the ECG. Previously, the most common thing that was looked into in ECG is the QRS duration, but now they have found that it's important to look into a relatively new finding called fragmented QRS. If you have fragmented QRS, it means that you have a much higher chance of sudden death on follow-up. And it's very important because, see, this is a study where they analyzed 147 cases of sudden death post-congenital repair in the long term. And if you see, by far, tetralogy is the leading cause of mortality in terms of sudden death, much more than most other forms of treated forms of congenital heart disease. And MRI is, of course, the major decision maker. So in my practice, I prefer to get an MRI somewhere between 5 to 10 years of age, as soon as it can be done without an intubation. And then every 2 to 3 years for a high-risk case, and every 5 years for a low-risk case. And if you look at what you're trying to follow up in MRI is the RV volumes. So if you look at the RV volume graph, this is the way the RV volume graph is going to move. In the first few years after tetralogy correction, the graph, your RV indexed volume is going to shoot up. You don't have to get worried about it, because by 5 to 7 years, it steadies out and then stays static for the next 10 to 15 to 20 years. And then, you don't know, by around the second decade, the RV volume starts shooting up in a select subset of patients. And those are the patients who are going to get affected, and they are the ones we need to follow up. So always remember that chronic PR is a mechanoelectrical disease. There are multiple causes for RV dysfunction in post-tetralogy, but the most important that when you see a patient is 2 things. What you ask is, will the patient require a PVR? Is there a need to do an EP study? because those are the two most common causes of death. And if you look at the current guidelines, we've evolved into this guideline, which is not the perfect one, but it's still evolving. And this was crystallized in 2012, and now we are still trying to evolve better ways to find out who will require and benefit maximum from from a PVR. What I follow is I follow that criteria, plus I add another age, because it's been clearly shown in studies that early PVR is very detrimental in children. So I always, if the patient is below 15 years, I really need a reason to go in and replace the valve. But if the patient is above 20 years, I'm more liberal with placing a valve. So the PVR, like the meningioma of neurosurgeons, PVR is a darling of pediatric cardiac surgeons. We love that operation because it's an easy case to do. But nevertheless, it's a complex situation because of the redo, and multiple other red flags can be present during a PVR. The most important is tricuspid regurgitation because it's hard to repair, a calcified RVOT, it's difficult to implant the valve, and a hugely dilated RV, and 20% of patients usually present with LV dysfunction also. So these are some of the red flags that predispose a patient to sudden death. The choice of the valve is, of course, bioprosthetic valve, except Inspiris. Inspiris in multiple studies across the world has been shown to produce moderate regurgitation in the short to medium term. So sorry, Edwards, if you're here. And pulmonary homograft, tri-leaflets, hand-sewn leaflet, and mechanical valve, if you have to place another mechanical valve in another position, like an aortic replacement. Mechanical valves do well in the pulmonary position, actually. Avoid bileaflet monocusps. It's a fairly straightforward operation, and luckily somebody has already done a paper on it, so I just take those images, borrow those images. I usually prefer a bicaval cannulation because of the issue of usually the recurrent airlock, blood coming into the RVOT. Longitudinal incision is placed on the PA. The PA annulus is sized. Patch of bovine pericardium is used to create the roof. The valves are excised. The bioprosthetic is placed with a single 3O or 4O polypropylene suture. It's sutured onto the anterior hood. An important thing that needs to be looked into is you need to tilt the valve a bit anterior so that you are able to place a much higher size of valve. And an important thing is when you place the struts, make sure it's like an inverted bend sign so that the two struts are there and it doesn't go and obstruct the pulmonary branch orifices. And another important thing that I just learned while making this slide is that it's probably better to put in a mitral valve because of the lower profile. It will sit better into the pulmonary route and it will produce less PA issues. Now, the biggest party wrecker in this is having a residual VSD or a PFO, which is very easily missed on pre-op evaluation. And so it's very important that you go through the images very clearly before you do a PVR. Always put in a TE, and the moment you open the RV, you make sure that you don't have air getting into the left side. And if you have any sort of air, immediately put in a root vent, aortic root vent, and make sure that the air doesn't go into the brain. This is in fact not the exact image, but one of my patients who had residual PFO that was missed in the pre-op evaluation. And the only thing is during the surgery, the anesthetist noticed a drop in NIRS to 30s. And he warned us. We said, yeah, it's okay, go ahead. And we just went ahead. And the unfortunate thing is the patient didn't wake up the next day morning. We took for a CT and had pneumocephalus. And, a relatively simple operation became a fatal operation for the kid. And is PVR beneficial? Yes. There's been a lot of, doubts whether it was very clear that it does improve RV volumes, it improves LV function, RV function, it produces a better functional class, but there was a big doubt that does it actually reduce deaths in the long term and reduce VT? but this is one of the last trial that has come and has shown that it produces significant reduction in deaths in the long term. This is a large international registry called the Indicator Registry, which is used for long-term top follow-up. So transcatheter PVI, the last, it started off as a valve-in-valve procedure, but now it's coming into the native. You got a list of native RVOT pulmonary valves which can be placed. But always remember the major two complications. One is left main coronary compression, which is common in this subset, and the other is increasing incidence of infective endocarditis, which is like 5 to 10 times the incidence of a surgical PVR. And the problem, it's unlike surgical PVR where you have a peak of infective endocarditis early on and then it subsides. No, all these valves have a growing linear incidence of infective endocarditis as time goes. And this is probably one of the reasons why I wouldn't, till the technology becomes better, I wouldn't advise transcatheter PVR. So the take-home message is, we've just prepared tetralogy to another chronic disease. Chronic PVR is a mechanoelectrical disease. The two causes of death, cardiac failure and sudden death. PVR is a relatively safe and simple operation, and always remember to keep it that way. And high incidence of infective endocarditis with transcatheter procedures. Thank you.
Thomas, nice presentation. The thing is, I noticed that you had put the bioprosthetic valve as the first choice, and then after that the mechanical valve, and then the last you had put as the tri-leaflet. In my experience, I feel that the tri-leaflet probably should come first.
My tri-leaflet is actually higher.
Okay.
In my personal practice, I put tri-leaflet because that's the one that the patients afford. And there's one series of paper from China where they've analyzed 24 series specifically in case of post-TOF pulmonary replacements. And they've shown significant reduction in RV volumes. And the next advantage, as you would say, is that they are much more easier to amenable to transcatheter pulmonary replacements also.
Correct. Between mechanical and bioprosthetic, you would prefer a bioprosthetic?
Yes, sir, as of now.
Why?
One is the bioprosthetics, the need for anticoagulation is tops. So most of the studies have analyzed incidence of long-term mortality after valve replacements. But if you take into the additional morbidity produced by the thromboembolic complications, even though the advantage of mechanical valves in the pulmonary position is you can thrombolyze them much safer than other positions because you don't have to worry about emboli being thrown into the systemic circulation. So, but nevertheless, the maintenance of anticoagulation, bioprosthetics seems to do well these days.
Thomas, nice presentation.
Thank you.
I do agree with you. Bioprosthetic is probably the path to go. And currently we are doing a study on post-op tetralogy and funded by ICMR and we have enrolled around 900 patients now. Nearly around 80 pulmonary valve replacements. So of the 80, probably 70 would have received a bioprosthetic valve. So we're just following them up and we'll get you the results. But the thing is that you can replace a pulmonary valve, make it competent. The crux is that how does the RV recover after being dilated. Like we have operated patients with RV and diastolic volumes of 250 plus. Yeah. And they just struggle through the ICU. But I still wonder how it will benefit in the long term. So we need to wait and watch.
Yeah. Once it crosses 200, RV EDV crosses 200 indexed and RV ESV crosses 95. There's still the benefit of PVR. it depends upon, with using this current criteria, we are still missing a few patients who would benefit, and we are actually overdoing a few patients who would have done well without a PVR. That's the crux of the criteria that we are using now. So it still needs revision. It's going to take another probably 10 to 15 years to, follow up of this, to refine the criteria. So till then we'll have to be finding reasons to put in a valve and then put in it.
I agree with you. If you are using a mechanical valve, I mean, this is more for the younger generation. If you're looking at a mechanical valve, would you prefer a bileaflet or would you prefer a monoleaflet? If you are using a monoleaflet or a bileaflet, what would the orientation be ideally? I think, Baiju, any experience? Because I have put in both monoleaflet as well as bileaflet, and my preference is to keep the greater orifice anteriorly so that the leaflet just moves in and out into the RVOT rather than go into the pulmonary artery. That is one. The second thing is when you use bileaflet, probably orient it vertical to the septum.
So that, goes into both PAs or something.
I'm really worried about using a mechanical valve in the pulmonary position. And I think homograph is the idea. But we don't get enough to put all homograph for all those things. We have been using bioprosthetic valves, especially Flumero, because it's cheaper and available at much lower rate. We will come out with the result. We have put more than 60 Flumeros so far in pulmonary position. Early result is fair. We need to wait and watch because the crux about bioprosthetic is how long they last, and you should not make them worse with the pulmonary stenosis.
The bioprosthetic, we are using Magna E's till now. So Inspiris is out. Inspiris, because the strut gets, it has actually it's an expandable strut. So when you place it in a position where there is no annulus or a rigid annulus, it stretches out and then it tilts, and that's why this incompetence occurs. So Magna E's is the only one that's available now. So the one that's 25, 27 are the ones that usually we use.
Just to understand, Thomas, the patients when you use pulmonary valve replacement, what is the RVSP pressure that you come off with usually?
We never check.
Gotcha. Because the elevated RVSP pressures, those patients can have mechanical valves. Because then you have a high flow physiology like this situation where mechanical valves may do well.
Mechanical valve is more of a bias against mechanical valve. It's a mental bias against mechanical valve than, hard truth. There are only 3 papers that looked into mechanical valve. The conclusions are, they are safe and good. But when you read through, the percentages are in double digits of adverse events. So,
I think the answer is put the biggest bioprosthetic valve available. Because it's not a big deal to enlarge the RVOT. Yeah. You put a patch, put the best bioprosthetic, the biggest bioprosthetic valve you can put, and then let's hope for the best.
Thank you.
Thank you. Just one question. Can I? One of the questions, Dr. Thompson, just one. This is just for the purpose of postgraduate education. You mentioned about the tricuspid regurgitation and calcification of the outflow tract as a problem.
Yes.
Is the tricuspid regurgitation a result of distortion of the septal chorda because of right ventricular hypertrophy? Is that a reason one should aim to do tetralogy of Fallot electively in the infant stage, the stage of infancy, 4 months, 6 months? Should it be a prescription? Because, the lung complications, the cerebral complication, the cardiac complication, cerebral maturity, etc. are compromised as you progress beyond 2 years and all that. So if you had a choice, would you be operating 6 months of age for tetralogy?
Yes, sir.
You would do?
Yes, as of now, we prefer to operate tetralogies as of like anywhere above 4 to 6 months.
That's a choice. That's a choice.
That's a choice.
And the age of operation on tetralogy fellow does not influence the incidence of transannular patch, which was the older teaching, very older teaching.
Correct.
Is that true?
The incidence of transannular patch will tend to be higher when you operate at younger age, but that's probably because they have a worse form of disease and you are forced to operate them at a worse form of disease. Just last week I operated a 2-month-old child. No transannular patch needed that actually. It had a very tight stenosis at the infundibular level and the annulus will grow. So if you take the group of symptomatic TOFs that we have operated at younger age, they are likely to receive a higher transannular patch.
Suppose you get a good TOF and patient is willing to undergo surgery at 4 months, certainly you go for that.
At 4 months?
4 months of age.
4 months of age. If it's asymptomatic, saturations are good, I would still push to beyond 6 months of age.
6 months of age.
Yes.
Okay.
6 months. But beyond 6 months, we don't find any benefit in waiting beyond 6 months.
Left anterior hemi block would persuade you for some pacemaker preparation?
LAHB alone. That's for the bit for the cardiologist, but just by the fact that you have LAHB, the problem is the traditional thought was after tetralogy repair you introduced RBBB also. So RBBB plus LAHB is a traditional indication for a pacemaker. But the RBBB that you see in post-off repair, it's not usually due to a conduction block, but it's due to a peripheral conduction block because of the aggressive resection that we do. So traditionally, if they maintain a good rate after, I've not had in my experience a patient coming with isolated LAHB. But if there is an LAHB, it would depend on the grade of block or the grade of the QRS prolongation or that is induced. And if there is any suspicion, we would definitely like to place an epicardial pacemaker at that point.
Are we tilting towards the right ventricular approach versus the right atrial approach?
Right atrial approach.
Still right atrial approach is a choice.
Right atrial approach is a choice. Especially we found that if you go through a transventricular approach for VSD closure, you tend to put in a larger ventriculotomy. So to avoid these larger ventriculotomies, we still go for transatrial VSD closure and repair of the RVOT as deemed by the anatomy.
Thank you very much indeed.
Thank you, sir.
We'll go on to the last talk. I'll invite Dr. Jagannath for Fontan failure management. Thank you.
Thank you, Dr. Jaykumar, Dr. Vinita, and the excellent team at KOTTAYAM who have made our stay extremely comfortable and interesting too, and for this opportunity to present my thoughts on a failing Fontan circulation. Dr. Sachin Talwar has actually made my life very simple, and I can skip quite a few of the slides. This slide shows you the evolution which has already been explained by Dr. Sachin Talwar. Now this is the original paper which was presented by Francis Fontan and Robotic. You can see actually you can actually see how the Fontan was done. It was evaluated by an angiogram, and this is the original paper. On the left hand side, you have the various stages of Fontan which has occurred. Now, again, Dr. Sachin Talwar has told you about what is the Fontan anatomy and physiology. The anatomy is basically what is depicted in the picture over there. You can see that there is direct communication between the systemic venous drainage and the pulmonary artery, removing the subpulmonary right ventricle. What does that mean? Is that there is lack of pulsatility in the pulmonary vasculature, and when that happens, there is inability to recruit the pulmonary vascular tree, especially during exercise. And usually these are in complex situations, and therefore there will always be pre-existing pulmonary vascular abnormalities. In addition to that, what you have is that a fenestration will improve the cardiac output, yes, but at the expense of saturation. Now the graph on the right hand side actually depicts that both the systemic vascular resistance and the pulmonary vascular resistance are now in series, and it is supported by a single ventricle, and the only valve which is competent in that particular situation is the atrioventricular valve, which decides how the PVR is affected. Of course, there is a muscle pump and a respiratory pump which adds a little bit to the pulmonary vascular resistance. So now, having seen what is a Fontan circuit, let's look at what is an ideal Fontan. Now, this paper about optimizing the Fontan was based on 455 patients from 79 to 2014. 385 or 88 of these have survived at least 6 months, and 116 were late survivors, and they showed that CVP less than 10 is ideal Fontan. CVP between 10 to 14 is associated with good survival up to 15 to 20 years age. Associated with this, you should have saturations which are greater than 94%. If these three criteria are met, you will have ideal long-term survival. In addition to that, if the end diastolic volume index is less than 74 and the ejection fraction is greater than 55%, then you have all the characteristics of an ideal Fontan operation. Now the cardiac output is basically dependent upon the LV EDP as well as the LV inflow, which again is dependent upon the absence of a subpulmonary pump as well as the pulmonary vascular resistance. And if the Fontan cardiac output is between 2.5 liters to 3 liters per meter square, only then you will have long-term Fontan. And this table summarizes what we have discussed till now. So now, having seen what is all the amount of ideal Fontan that we can generate, what are the chances that we can fail? Amongst all this, you can see that cardiac, pulmonary, gastrointestinal form the major amount of causes for the Fontan failure. In cardiac, it could either be ventricular, systolic, diastolic combined, because the Fontan ventricle can be either LV based or it can be RV based. RV is not supportive of systemic circulation in the long term, and if it is LV, chronic underfilling of the left ventricle in this situation generally induces both systolic and diastolic failure in the ventricle. AV valve regurgitation, I need not elaborate. Channel disruption, even though you have created the ideal Fontan circuit using the extracardiac pathway, there is still a clash of the two streams from the SVC as well as from the IVC, and this results in loss of kinetic pressure and can lead to Fontan failure. Collateral shunts result usually aortopulmonary will raise the pulmonary vascular resistance. Veno-venous will take it away from the. Now, if you're talking about arrhythmia, the cardiac output is actually related very frequently to both atrial as well as ventricular arrhythmias. In spite of being an extracardiac Fontan, the contribution of sinus node is extremely important. So now, if you look at pathophysiology and look at how we can use medication, these are the possible. This one, in interest of time, I'm skipping it a little bit so that we can go in faster. Now, there are two modes of failing Fontan. The first mode is where you have a high CVP and a low cardiac output, and these are usually related to surgically correctable causes or at least due to systemic ventricle which is failing. And the possible ways in which you can treat them is either using nitric oxide, use home oxygen therapy, you could use diuretics, ACE inhibitors, ARB2 inhibitors. All of these are basically to control heart failure. Whether manipulation of pulmonary vascular resistance can contribute significantly to the whole system. This paper showed that there is no available evidence in either ways. This is the newer Fontan failure which is being described lately, where you have a high output but associated with a high CVP2. Here, traditional anti-failure methods will not work very well. You will need to use a vasoconstrictor in this situation. There is one more way of treating, which is called as a super Fontan. In super Fontan, what you do is you induce systemic vascular resistance drop as well as you induce pulmonary vascular resistance drop by dilating both the things, and as well as increase the systemic venous capacitance. When you do all this, that is use of nitrates and vasodilators, you will be creating what is called a super Fontan. These things have a surgical option, that is you can repair or you can stent or you can recruit more amount of pulmonary vasculature by appropriate means. You can also repair the atrioventricular valve or the semilunar valve. Now, either you can have cardiac interventions in the form of valve repairs, or you could remove the anastomotic narrowings, conversion from atriopulmonary connection to total cavopulmonary connection, fenestration. If it is large, you can close. Fenestration, if it is small, you can reopen to ensure both adequate cardiac output as well as saturations. Now, two complications. One is protein losing enteropathy and the other one is plastic bronchitis. Plastic bronchitis, I have not seen many, but protein losing enteropathy, I think, is underdiagnosed in all patients. And this is basically because of inadequate lymphatic drainage. And I would draw your attention to this paper which talked about classifying the lymphatic drainage based on dynamic contrast enhanced magnetic resonance and a lymphangiogram. They classified it into 5 types, and type 1, 2, 3 is amenable for the Raska type of shunt, which diverts the lymphatic drainage into the left atrium or into the right atrium, depending upon where you can push it in. Type 4 is very amenable for conversion into directly anastomosis between the thoracic duct and the systemic venous connection, and then doing a Raska shunt. Whatever you do, surgical interventions is not associated with great outcomes. There is actually one more paper which talks about personalization of the Fontan, newer things like tissue engineering the Fontan pathway so that it allows for growth, overcoming the Fontan paradox. The Fontan paradox is usually when you have a raise in CVP, the cardiac output should increase, but however here when you have a raise in CVP, the cardiac output actually falls because of the Fontan pathway. In this situation, you could use the devices which actually raise the Fontan circuit pressure by about 3 to 5 millimeters. There is what is called as an injector technology, where you put a small shunt, 3 millimeter or so, into the SVC, and it acts like injector using the Poiseuille's, not the Poiseuille's, the injector gun, where high pressure flow generates much better flow into the pulmonary vascular resistance. Into the pulmonary tree. Or you could use regenerative medicine. So, to conclude, Fontan circulation, it was a great breakthrough surgery for single ventricle, both anatomical and physiological, but at best is a palliation. The clock starts ticking the moment you think about single ventricle pathway. It starts the clock when you do the Glenn, and when you do the Glenn, it speeds up, and when you complete the Fontan, what happens is you start the countdown towards the failure. So, this is the best palliation we have for single ventricle physiology. Thank you. There are a lot more things on the slides, probably for this one. It summarizes what I am thinking about. Thank you.
Thank you, sir. Thank you, sir, for an excellent talk. What do you think about
Thank you.
One of the most common cause of failure of Fontan is considered as atrial arrhythmia or sinus node dysfunction in the long term. So, what are your thoughts about prophylactic pacing lead into the atrium at the time of Fontan? So there are some papers which suggest that anyway they will need they will undergo sinus node dysfunction in the future. So if you keep a pacing lead at the time of Fontan and bury it, later you can use it when the patient ultimately comes to sinus dysfunction.
Sorry, I couldn't get. What you are trying to ask is that arrhythmia produces...
arrhythmia produces failure. So do you put a prophylactic pacing lead at the time of Fontan itself?
Permanent lead.
Permanent lead at the time of Fontan itself?
Not really. Basically, if it is a single ventricle, anatomical single ventricle situation, chances of heart block are pretty low with the extracardiac Fontan. Whereas if it is a biventricular repair and you have attempted a biventricular repair and then converted back into a Fontan, yes, you might have some amount of arrhythmia. What I have seen or personally experienced, arrhythmia is not a very common cause. More common is protein losing enteropathy. Even the plastic bronchitis is very rare from what I have seen. The reason probably may be because the follow-up has not been that adequate. Maybe we are missing out people who actually have failed. So I don't believe in putting in permanent pacing leads. It's better to it's better to wait. If there is any issue, you can always go in with a small subxiphoid incision and put in epicardial pacing leads.
Thank you, sir. Thank you for that excellent session. We will go on to the next session. Thank you.
Thank you, panelists and speakers and audience for such an innovative, interactive, educative session. Commercial stalls are arranged in sports square next to the hall. Please find time to visit the stalls while you grab your coffee.
Moving on to the next session. The advances in CTVS is more in thoracic than in cardiac part. Minimally invasive procedure approaches and robotic surgeries have become very popular across the globe. Today, we have very distinguished thoracic surgical faculty for this session.
And I invite respected chairpersons to occupy the dais and start the session. Dr. T.D. Ravikumar, Professor and HOD, CBTS, Government Medical College, Thiruvananthapuram, Kerala. Dr. Harlal Nambiar, Chief of Cardiothoracic and Vascular Surgery in Baby Memorial Hospital, Kozhikode, Almas Hospital, Kottayam. Dr. Ravi Krishnan J, Associate Professor, Department of CBTS, Government Medical College, Kannur, Kerala. We are running short of time. Kindly stick to the time for presentations.
We are coming to the 8th session of this meeting, mainly into thoracic surgery. So there are 4 topics, and the first topic is by Dr. Sri Krishna from Narayana Hridaya Institute. He will be speaking about tracheal reconstruction methods. Over to you, sir.
Good morning. At the outset, I must thank the organizers, Dr. Jaikumar and Vinita and the team for this opportunity and also their excellent hospitality. Disorders of the trachea is a domain of multiple surgical specialties. Thoracic surgeons are the main. However, general surgeons, trauma surgeons, ENT surgeons, head and neck surgeons, and thyroid surgeons are also involved in the management of these disorders. These are the pioneers of tracheal surgery, which started way back in 1960s. Griffith Grierson and Hermes Grillo were the pioneers at that time, and along with them 2 French surgeons, Espace and Kurat, and also a Russian surgeon called Perelman were there. We must not also forget Dr. Rajan Santoshan, who pioneered tracheal surgery in India. What are the indications for surgery in tracheal surgery? These are the common indications. Post-intubation tracheal stenosis and tracheobronchial tumors are the most common. Of course, there are other conditions as well. The principles of tracheal surgery, the pre-op evaluation and airway management is of utmost importance. However, the other things that I have mentioned in the slide are also important, but pre-op evaluation takes precedence. The peculiarity of the anatomy of the trachea makes it a difficult organ to operate upon and achieve a favorable result. There is at present no artificial substitute to the native trachea, and therefore only 4 to 5 centimeters of the trachea can be removed and achieve a tension-free continuity. Tracheal lesions usually present with symptoms and signs of obstructive pattern, which could be either fixed, variable, intrathoracic, or extrathoracic obstruction. Pre-op evaluation, as already alluded to, involves delineation of the site and extent of the lesion, distances from the vocal cords and the carina, amount of trachea that can be safely removed. To that effect, imaging and preoperative bronchoscopy is extremely important. This is a slide depicting the imaging, various imaging modality. This is the CT scan with a 3D reconstruction, virtual endoscopy, and dynamic imaging during respiration. This is important in assessing tracheomalacia. MRI is extremely useful, especially in assessing tumors of the trachea with extratracheal involvement and involvement of the surrounding structures, as well as in pediatric patients to avoid IV contrast and a long ionizing radiation. This slide depicts the various sites of tracheal lesions and also describes the mechanism of acquiring post-intubation stenosis. The pressure on the mucosa can lead to ischemia and eventual necrosis of the rings, causing scarring and stenosis. Airway management is, as mentioned earlier, is crucial in these cases. If the airway is less than 6 millimeters, pre-op dilatation may be necessary and should be done in a controlled environment like in an operating theater, because they can end up with an acute respiratory compromise. Outpatient management should be condemned. Sorry, not discouraged, it should be discouraged. If the airway is more than 6 millimeters, you can use a fiber optic guided intubation around the tumor or through the tumor and then achieve airway patency. Debulking of the tumor with a snare, electrocautery, laser fulguration, or even excision through a rigidoscope prior to intubation can be done. Use of CPB and ECMO have been described, but although they are rarely ever required. The anesthetic consideration maintains spontaneous ventilation, cross-field ventilation during anastomosis, spontaneous ventilation at the end of the procedure, and early extubation at the end of the procedure should be the norm. Various approaches to the trachea are described. It depends on the site of the lesion and the type of procedure that you are going to do. Cervical collar incision can be used for most benign intubation stenosis. Tumors with extra involvement may require a partial or a complete sternotomy along with the cervical incision or use of a clamshell incision. The right posterolateral thoracotomy is used when the lesion is closer to the carina in the chest. Special situations. Sometimes it may be necessary to gain extra length of the proximal and distal trachea to achieve a tension-free anastomosis. To this effect, various maneuvers have been described as depicted in this slide. Due to lack of time, I am not going to go into all the details. The one most commonly used is the Montgomery suprahyoid laryngeal release, where the mylohyoid, the geniohyoid, and the stylohyoid muscles are divided, along with transection of the lesser cornea of the hyoid bone. This gives an additional 1 centimeter length, allowing a tension-free anastomosis. Dr. Pearson described this technique for subglottic stenosis, which is very close to the cricoid, and he used an oblique incision to safeguard the recurrent laryngeal nerve and allowing preservation of the vocal cord function, which is very important in the post-operative period. Nowadays, the dictum is to preserve as much of normal lung as possible, and hence even in carinal tumors, which were previously termed inoperable or end up with a pneumonectomy, can be dealt with sleeve resections. This usually involves a transthoracic approach, either through a right posterolateral thoracotomy or a clamshell. However, nowadays we are even able to do these sleeve resections by minimal invasive techniques like robotic surgery, which I will show you later. Tracheoesophageal fistula, formidable sequelae following a bad tracheostomy, tube management, malignant invasion of the esophageal or tracheal tumors, or more commonly nowadays by the indiscriminate use of stents either in the esophagus or the trachea by intervention physicians. Management of airway trauma, this is more of an emergency or a semi-emergency procedure. You have to achieve airway patency as a primary procedure, and then assessment of the tracheal damage or a coincident esophageal damage by endoscopy, and then you have to go through the right, usually the right thoracotomy approach for repairing these lesions, unless it is high up in the neck where a collar incision can be used. Tracheoinnominate fistula are also possible, and this is again a sequelae of a bad tracheostomy tube management, because the angulation of the tracheostomy tube by the tubings can erode into the innominate artery in the front and cause massive bleeding. This can become a life-threatening emergency. Tracheal grafts. The latest advance is the use of stem cell regenerated tracheal grafts. This is still in the experimental stage with probably anecdotal cases, and maybe in a few years' time we will have good tracheal substitute. Some of the recent advances include less invasive endoscopic balloon dilatations and use of stents to tide over a situation, and then followed up by surgery. The various available stents are depicted here. By and large, we generally don't use a metallic stent in a benign disease. This should be the norm. And we use a silicone stent in a benign disease which can be replaced or tackled within 6 to 8 weeks later. Endobronchial therapy of web-like stenosis can be tackled by electrocautery or a laser, balloon dilatation, and then subsequent management of the airway. Again, an endobronchial tumor can be dealt with by a snare, electrocautery, laser, fulguration, or even excision through a rigid scope prior to intubation. This is a very rare procedure, not very commonly done, anterior mediastinal tracheostomy, which is used in very extensive tumors, and the various things have been for extensive tumors of the recurrent retropharyngeal and the mediastinal tumors, and I will not go into the details. The details can be available on the reference that is given below. This is our own experience of about 127 cases, both from my St. John's days and now in Narayana. Majority of them were post-intubation stenosis. 9 of them were post-traumatic tears or complete transections with cervical injuries. Tumors of the trachea were around 15. In the early in my experience early in the series, we did a combined cervical and thoracic approach, maybe just about 5 cases, and then, but as our expertise improved, we are able to manage most of the cases through cervical route alone or a right thoracotomy for lesions closer to the carina. I'll briefly run through the steps of the operation for a benign tracheal stenosis. The airway is managed by balloon dilatation and then subsequent intubation. You can use a 5.5 or a 6 mm tube to maintain till we get the distal control. A collar incision is used, skin and platysma are raised, then the pretracheal fascia is exposed. Here the trachea is divided. Sorry. The trachea is divided just distal to the lesion, and distal elevation is taken, and then there is proximal control is then the proximal area of the trachea is divided, and then the 2 edges are brought without tension, and then the anastomosis is done. I had a few representative cases, but because of the lack of time, I will quickly go on to the last case, which is interesting. This was a case of a carcinoid in the right main bronchus, and in a housewife. With a carcinoid in the right main bronchus in a 33-year-old housewife occluding the right upper lobe orifice. Robotic lung sparing procedure, excising the tumor bearing the right main bronchus and upper lobe bronchus, and reconstruction of the secondary carina and bronchoplastic reconstruction was done, not only avoiding a pneumonectomy but also preserving the entire lung. I will just show you a video. It's a 1.5 minute video how this was done. The hilar area is dissected, and then this is the area where we are isolating and looping the right upper lobe bronchus, and also the intermediate bronchus below. Then the upper lobe bronchus is divided, and the tumor bearing area on the upper lobe and the intermediate bronchus was excised, and both the upper lobe and the intermediate bronchus were completely divided, and the tumor bearing area was removed. Then we made a secondary carina by suturing the upper lobe to the intermediate bronchus, and then the whole thing was anastomosed to the trachea at the origin of the right main bronchus. So these are the various steps that we are doing this. Here the tumor bearing area is removed, and we are creating a secondary carina. On that side, that is the right upper lobe bronchus, and this low down is the intermediate bronchus. Just 1 minute more. These are called V-lock sutures. They have into this thing, you just pull it up and then it gets locked in there. And it's made of Vicryl with a coating on that, so that you can just It's like it's self-locking. You don't have to, somebody has to pull it, and once you have pulled it, it stays there. So it's very useful for robotic work. So this is formation of the secondary carina. And now we are taking a T-shaped stitch and anastomosing the posterior part onto the right main bronchus, and then we are closing the entire thing anteriorly. Sorry? There's a tube going across onto the left side. You can see during it is gone through the trachea onto the left lung. So in this case, which in the olden days we probably would have done a pneumonectomy, we were able to take out the complete tumor and save the entire lung, upper, middle and lower lobe. So it was a completely lung sparing operation. Thank you. This is just to show the...
Thank you for the very detailed description of most of the tracheal procedures. So one question, how do you try to preserve the vascularity of the trachea? What are your strategies?
Well, as we know, the vascularity of the trachea comes from the lateral aspect. So when you are wanting to mobilize, you only dissect in the anterior plane in the pretracheal fascia, and once you divide, go around the thing at the site of the lesion where you are going to excise the trachea, and once we divided the trachea, you lift it up and go on to the posterior side proximally, and so that the entire thing comes closer. You put two stay sutures on either side, bring them approximate to the side, and then make sure that it is not under tension, and along with some little neck flexion, and then do the anastomosis. Earlier we used to do entire thing in interrupted sutures using 3-0 vicryl. Nowadays we use PDS, 3-0 PDS. Posterior layer, the membranous layer is done continuous, and the anterior layer is done by interrupted sutures. And when we are approximating that, you should not be doing it in one way. It should be slowly from both sides. You start tying them so that the approximation and the pressure is distributed. That is something that has to be followed.
Sir, post-intubation tracheal stenosis, like when will you decide whether you are going for an endoscopic procedure versus a tracheal resection? That's number one.
Everything is done after doing a 3D CT scan and assessment. If the tumor is less than 6 if the lumen is less than 6 millimeters, we will probably do a dilatation either by bougies or balloon dilatation and in the table in the theater just before intubation, and then we can pass a 5.5 tube or 6 mm tube, and that will suffice for you till you get the distal control, and then you do a cross-field ventilation.
Sir, my question is many times what we do is we do a repeated dilatations and patient will hang.
Yes.
But is it good, or you have to sometimes...
As I said, repeated dilatation can cause sudden edema of the area and can cause acute respiratory compromise. So it is not an advocated thing to be done as an outpatient or in a bronchoscopy room. It should be done in the theater. We always follow that in the theater.
Same with another thing is when will you decide you will go for a cervical or the right thoracotomy approach? Because sometimes you may have the stenosis little bit in the intermediate area. You may find it difficult to reach from the neck, and then you are in a dilemma whether to go for a right thoracotomy or not. So
yeah, as in that slide I showed you, most benign strictures can be handled in the cervical region. But if it is closer to the carina, at least 4 centimeters from the carina, it is better approached by the right thoracotomy. In the right thoracotomy, you can also approach the left main bronchus as well.
The video is very interesting. Now that you mentioned carcinoid, if you see a bit of calcium on the tracheal cartilage at the point of resection, would you suspect that that's a residual disease in the stump? Or there is a statement that presence of calcium in a carcinoid situation, suggestive residual carcinoid. I had gone through a redo carcinoid to complete a pneumonectomy, and I found a little calcium. Somehow I managed to make a wedge incision and salvage, a sleeve tracheal procedure, sleeve pneumonectomy on the right side. So what would be your experience?
We always try to do an on-table frozen section of the two cut-end margins, make sure that most of it is free.
Yeah.
However, even though you have to keep in mind that the amount of trachea that we are going to remove is not more than 4 centimeters.
Yes.
Because if it is, then there is a point of no return. We can't do anything more. So in spite of that, if we find little residual tumor, especially adenoid cystic carcinoma or residual carcinoid, we may still leave it and then achieve anastomosis and subsequently look at it later on.
You don't go for sleeve pneumonectomy?
No. I mean, if it is amenable, we can do that. Like in the last case, in the video I saw, the upper lobe orifice was, it was occluding the upper lobe and extending on to the portion of the intermediate bronchus. So we excised the whole thing. In fact, there is a slide depicting that. Can we get the slide on? Can we get that slide on? Of exactly how we manage the tumor and saving the lung.
And also, if there are gas exchange issues, you could have 2 Boyle's apparatus.
Sorry, sir?
You can have 2 anesthetic machines separately ventilating the lungs.
Yeah, but it's not generally necessary, because once you've got the distal control, you can use a tube through the operating field, cross-field ventilation, and that will allow you enough time and enough this thing. Maybe just when we are doing the posterior anastomosis,
yes,
we can take it out and then do the posterior anastomosis, yes, and put back the tube.
One more question. One question. This is regarding post-operative management. This chin stitch is not well tolerated by some of these patients. Is there any prosthesis or collar which can be used in these patients?
Yes, I had made my own one modification of the sternovertebral brace. I didn't show this. We have a brace that the occipital ring and the sternal, which sits in front and back, so that for cervical spine injury, I modified that and made only for the tracheal this thing to hold it back. But most of the time, if you have a tension-free anastomosis, they will manage. You need it only for 7 days. Post-op management requires humidified oxygen and then a low threshold for tracheobronchial toileting with a fiber scope. It should be available in the ICU.
Second thing, in your practice you mentioned MRI. Usually we stop with CT. When do we need to do MRI in any subset?
If there is a tumor. If there is a tumor and we think that there is an extension outside the trachea, and that may cause problems to the surrounding structures in the mediastinum or in the neck, then maybe an MR would be useful.
Thank you.
Just to answer that question about the, normally we use a cervical collar in the reverse direction. Just that will suffice. But technically it's for the surgeon's sake. It really doesn't affect an anastomosis at all. And CT is generally good enough.
Thank you, sir, for the excellent talk. Now we'll move on to the next topic by Dr. Darlong regarding the management of Pectus excavatum. Over to you, sir.
Good morning, everybody. I would like to thank the organizing team for having me here, especially Jayakumar sir and Vinita, for whom I'm interacting. I'll be speaking on Pectus excavatum, its management. Yes. Okay. So, first of all, greetings to you all from Rajiv Gandhi Cancer Institute. I'll be speaking on Pectus excavatum, its management. First of all, a brief introduction. It's the most common congenital...
Excuse me, the slides are not coming.
So Pectus excavatum, I'll just give a brief introduction. It's the most common congenital chest wall abnormality. And it's a myth regarding calcium and vitamin D deficiency. It is not true because most of them come loaded with calcium and vitamin D and they've got tested a million times. And symptom-wise, if we see, they are mostly asymptomatic and they don't cause much problem with a sedentary lifestyle. It's the parents who start recognizing it, and at teenagers, when we become aware about the body, with YouTube coming in and a lot of influenza, that's when they have that feeling something is wrong with them, and they can have some non-specific symptoms, and most of them are basically like chest pain and sometimes palpitation. And to diagnose, it's not complicated. It's just basically it's a morphological diagnosis. You see, you know exactly what it is. It is not to be confused with carinatum deformity, wherein it's basically the chest wall is coming out, or in arcuatum deformity, wherein you have in both excavatum and carinatum. But in these, the bones are very, very stiff. This happens especially in a child also, who is about 5 years, 4 years, even at a very young age. These bones are rigid. You can never use a bar to correct these conditions. Imaging, we do use the CT chest. It gives us an idea about the Harris index, the index of severity, about some sternal rotation, as well as some amount of rotation. Is it symmetrical or asymmetrical? Another test like pulmonary function test can be done, but mostly are normal. It's only when they are at stress that there can be some change, but it doesn't really reflect the real situation. 2D echo helps gives an idea about some amount of mitral valve perhaps because of the pressure on the underlying heart. So this is a CT scan just to give us an idea whether defect is symmetrical, asymmetrical, is it deep, focal, if it is asymmetrical, more on the right side, left side. So this all they have got a bearing implication in terms of the management. Asymmetrical deformity gets corrected more easily and better corrected. Asymmetrical ones are more difficult to correct. Satisfaction rate is again more lower. And most important question is about the time to repair. When do you repair a Pectus excavatum? There are no consensus regarding when this particular disease needs to be repaired. The thinking is that if you do it early, the bones are soft, they are malleable, so you can have good correction with less pain. It is more acceptable. But again, in adults again, if we see, the bones are hard, more hard, so it becomes more painful and you require more bars. You require at least 2 bars minimum and not single, unlike in children's. So in the beginning, and many places and a few centers, they do it at the age of 3 years. They have selected 3 years because the bars is kept in place for 2 years, and by the time the child becomes 5 years, the bar is taken out and the child is ready to go to school, and they don't have the stigma of what they can face in school with activities like showing their body. So the child gets rid of the stigma with chest wall deformities. So if we go ahead and look at indications, there are no randomized controlled trial to say this is an indication. It is basically the patient's desire, which is most important for psychological and cosmetic reasons. And when we correct this, So we expect some amount of correction in cardiopulmonary function by increasing the stroke volume, but these are usually not very much measurable. And of course the CT index, that's the Heller index, it's more than 3.2. It gives an idea about the severity. It helps us clear the insurance, because all these cases are not what I call covered by insurance. It's only the corporate insurance, group insurance they cover. So anything above more than 3.2, they get cleared from the insurance for a repair. So the surgical repair is a minimally invasive repair, we call it MIRP, and the NUS procedure was originally designed by Professor Nuss from Children's Hospital King Disease in 1986, and he published it after 10 years in 1997. And what we are practicing now is basically the modified Nuss procedure. This is the basics of the Nuss procedure. You can see that it's basically remodeling the chest wall. A bar is placed under the sternum after getting rotated to the desired model, and that how the ribs and the sternum gets remodeled over a period of 2 to 3 years. Original Nuss was basically for children, and it was used only for symmetric deformities. It was a blind procedure because in those times they did not have the thoracoscope. Thoracoscope came by 1998, and it was before that era that this procedure was done. So I will just go to what our technique is, because every surgeon who is doing Pectus has a different way of dealing with this condition. There are no set guidelines how you do it. The main thing is that you need a stable bar, you need a good correction, morphologically corrected deformity, which the patient is expecting. So we started off with a 3-year-old child, like how I said in the beginning, with the soft bones. These are cases where the parents are very much motivated. The child is also aware of the condition. And this is the image. You can see it's symmetrical, the central deformity. A single bar was used in this case. And that's the image post-op. You can see here in the center was what was pre-op, and that's post-op. This is the CT chest before and after. You can see there's a very well-corrected deformity, and the bar is again removed at 5 years. So the limitation of doing this is that it is indicated just for symmetric. We don't know what is going to happen once you remove the bar, because they might grow in asymmetric condition. So it's always very unpredictable. So now we practice is that we don't do more in children. We wait till the age of 14, and like in this case, which is below 13 years, I would prefer to wait and give a vacuum belt, trial of it, and then wait for it. If it's have some residual, then we'll go and do a surgery at the age of 14. This is the Nuss procedure, a basic Nuss wherein we are using 2 bars. This is how that we're going to do a crane lift and increase the space in the retrosternal space, and we'll use the sternal wire, hook this into a sternal bone, and then lift it with a modified root track retractor. So we put a scope here. This from right chest. I can see in this area. I just lift up more the sternum, and then I create space in the retrosternal area from the right side. You can see here on the vision, I can basically go in to the other side. So once I've gone from the right side, I come back from the left side, just take a nick on the mediastinal pleura, and then open this whole space in the retrosternal area. So this way I can basically see the area on both sides where my bars are going to get fixed, and I can safely place the bar in the desired location. That's how the bar is placed from this is the chest tube we place here. 2 chest tubes are placed in a cross fashion in this case, because we are planning to do a cross bar. So I can put my scope even inside this chest tube, which we call Pectus sternaloscopy, which gives me an idea about exactly what is inside that, any bleeding that I have in the retrosternal area. So this gives me a good vision. It's using a 5mm 0° scope, and then once we've done that, we place the bar basically under vision, under again guiding it from all the way from the left to right or right to left, which we call Pectus sternaloscopy, guided insertion of the tube. So once you're done with this, you can basically take it out and then take out a scope, and then you rotate the bar. This is how it looks like from the outside view. So it's important on table that we keep bending our bars. Initially you might have to do it more times, but as you gain experience, the remodeling of this bar becomes much easier, because we need to elevate those sides which are depressed and not elevate further any side which is elevated. So we have to model the bar accordingly. This is the bridge technique we use in our cases. We have published this sometime in 2016, and this is some way of making the bar stable, because all our patients come from far away. And this is again using the X bar or the cross bar. You can see the deformity is central, quite low down, and then that's how the X or cross bar is going to be placed. So under vision, you can see here, it's an external view. I'm going to flip the bar in the X fashion. Once I flip the bar, you can see that the retractor, the sternal lift has basically gone off. It's just pushed off and away. So that's how we place two bars in the cross fashion, and that's how the image looks like on table. This was published again in 2020, and these are the images post-surgery, and again these are images post-surgery. So innovations is an important thing in Pectus surgery, and so the crane lift was described by Dr. Park. I have done a few bit of my innovation, that's Pectus stenoscopy, the moon bridge bar stabilization technique, and our crossbar technique, and of course the no crane lift technique, which we'll be publishing shortly, which is basically for severe deformities wherein 3 bars are placed. This is the Pectus stenoscopy we published in 2013, the moon bridge in 2016, and coming to the bar stability, which is the most crucial part of NUS procedure, because single bar is unstable. You always use 2 bars. Single bar has no value in adults because it is unstable. This was how we started off, using hinge plate, claw fixators, and this is how we used to fix the bar initially. But you can see here that bars can get displaced if it is unstable because of flipping, lateral displacement, or they could be stripping of the intercostal muscle. So this is an image you can see here where one of our bars is flipped. And it's important that this is a recipe for disaster. Any bar which flips or rotates is a recipe for disaster, because at bar removal they form undesired adhesions and they can cause injury to the heart, and a very, very what you call mortality like in bar removal. So the turning point was in September 2012 when we used it for pectus carinatum. We had to depress the sternum. That's when we use a T-plate which is available in the OT with our ortho department, and we fixed to that, and from that on we use this same idea for pectus excavatum using the 1/3 tubular plate. This is the 1/3 tubular plate which is easily available and it's MRI compatible. So this is how the bridge system, the moon bridge system came into being, and this is how it looks like. And once you're done with this is a very, very stable bar. But limitations of again a parallel bar is that, like you can see here at the lower end, this part is again not lifted well, because the force of application is again equally not distributed. That's when we came to the concept of crossbar for such cases, and that's we published our case series about 5 cases in 2020, and these are basically for symmetric deformity which are lower down in the sternum or asymmetrical. Like in this case, you can see it's a symmetrical deformity, central, and then again here it's central and lower down. So in this case, we use a crossbar, like see here from the top, and that's how the image looks like. We are basically lifting that particular side exactly precisely in a very stable fashion. And again, for asymmetric deformity, the parallel bars don't work. So we can use an asymmetric bar in right side or left side, like in this case for the right side, and again in this case for left sided, we can again use the crossbar in the left fashion, again like this. These are the images post-op. And some cases you cannot do away with 2 bars. They are too long segment or the bones are too hard. In that case, you require 3 bars. Like in this case, we have put 2 X bars, but again, the deformity was not well elevated. So we have to put a 3rd bar in XI fashion. And you can see our image that's post-op. And sometimes, if you can see here, the picture doesn't really say everything about it. It looks quite flat, doesn't look very, very severe. But if you see the CT scan, Haller's index is approximately 7.9. It's a very, very severe deformity. And this is how we use the no crane technique, or we call it no lift technique, wherein we place 3 bars. These are XI asymmetric bars. 3 have been placed. It is a pre-op image, and that's the post-op. You can see a significant difference. Again, in some cases, you can't put XI bar in a 3 bars. So we have again the no crane technique here. Here when we place 3 parallel bars, it's not necessary to put always XI. It has to be again a parallel. 3 bars are placed. And this is the image you can see pre-op, and this is post-op. So all the bars have to be removed at the end of 3 years. And what is important is that the bar should not be displaced or rotated during this period, because it's a recipe for disaster. And because of the neoacidification, we have a problem of wound infection, which we need to take care of right from the beginning. This is a bar removal, a straightforward case. You can see the plates are there. We have unscrewed the plates, and then we take out the plates here. And once we do that, we expose the the bar, and we make the bar straight as much as possible so we can put it out in a straight fashion. You can see that I'm just basically bending the bar, and I can pull out the bar easily. You see, I'm not applying any force without any resistance. It comes out easily like that. That's how the bar removal is done. Sometimes people don't take out the bar on time, and it can result in the ribs getting fused, like neossification. They can have chronic pain, and then sometimes we do need to localize the bar with C-arm, the side of the plate. Like this is a case wherein the patient had the surgery in 2008 from Germany, and he got the bar removed at 6 years. He had got it for a long time, and this resulted in the rib getting fused. So we had to go in, and despite conservative measures to relieve his pain, we had to go in and basically release the rib. You can see here, we're basically releasing the ribs and making the space. It's like a neurolysis and re-expanding the lung. That's the rib which was separated, and then you can see here, we have put again the plates there just to keep that in position so that they don't again come back to the contracted state with the rib. And that's how it looks like in the immediate post-op. You can see here, and that's the X-ray where the plate was placed. So during COVID, we had a lot of patients from international cases who had basically gone to the surgery done before the COVID, but with COVID, because of the delay, they're scared to come back to India. So we had cases wherein like they had delayed more than 6 years. And in such one of the cases, we had to use a C-arm to localize the plate on one side. You can see here, that's how we localize the C-arm, the plate on one side. And then once we localize, you can see that's the plate seen there. There's a lot of neossification. We had to use the hammer and chisel to basically break off all those new bones and then expose the bar, and then again, like in that case, we just flip it again easily this bar comes out. So to conclude, I would say that the diagnosis of Pectus excavatum is morphological. CT scan helps us in terms of insurance and giving us an idea about the symmetrical. Management is age dependent. Vacambal is preferred for age group of 8 to 13 years, and for surgery we prefer 14 years and onwards. Indication for surgery presently is basically the patient's choice, and 2 bar is optimal, which is required, and nothing less than 2 bars. You can go up to 3 bars, some people have gone to 4 bars, but I usually go up to 3 bars. Thank you very much. I think I've finished in time. I would like to thank Professor Nuss who gave us this beautiful technique, and Dr. Park who has been an innovator in all these cases.
Thank you for the excellent talk, sir. Is there any upper limit for this? Like you told, 14 years is the, you can, up to that you can wait.
Upper age limits, we don't have it in literature, but my oldest patient was 54 years. He was an American. He wanted to get it done, so he did it at 54 years.
But once the bone gets fixed, then...
Once the bone gets fixed, the thing is that we have to use 2 bars or maybe 3 bars. It is more painful.
Or any osteotomy to be done?
Osteossification, all these things are basically, it depends on how long the bar is inside. It's because of neossification.
The chest wall will not yield, no. So will you do some osteotomy?
No. Because in Nuss procedure, the concept is basically to remodel the chest wall. We are basically pushing the sternum, expecting the sternocondral junction to be pliable. It is not rigid. Unlike in ravage, where they excise the cartilage and make the procedure, what you call the deformity more contracting, if you see as such, because your cartilage, once you cut, they never heal. There'll always some amount of friction, some click sound will always be there, which we had initially in Pectus craniatum.
Any concern about mammary artery injury?
Yes, study has come showing that there's definitely memory injuries there. They can have problem in CABG in the future.
Okay. Any questions from the audience?
So do these bars comes in different sizes or?
Yes, bars come in different size. The smallest is 8 inch and it goes up to 15 inch. So most of our Indian patients are 11 inch, 12 inch. International patients are 14, 15 inch. So you decide the size of the bar on table.
Not on the CT?
No, not on the CT. Because like I've shown you, I sometimes try and do an X cross bar for low deformity, but you find the results are not good. Then you have to again change it to a parallel bar. You can never predict on the CT scan, anything like that, how it's going to lift. Because you want a morphological correction. Once you lift the sternum, how pliable is the sternocondral and the rib, that's very variable.
Thank you. This is very nice, very nice. I just want to know, was there a degree of cardiac compression in any of your cases?
Like the one I showed in 7.2 Heller's index, she had some mitral valve prolapse.
No, cardiac compression.
The degree of cardiac compression. So they do have cardiac compressions, so they have non-specific palpitation. So in echo, we basically look for any mitral valve prolapse. That's the maximum we see for it. Otherwise, in terms of ejection fraction, they are normal.
Do you do a metabolic bone disease survey before? Because there is a spectrum of things which comes with the...
So Pectus excavatum as such has got no relation to vitamin D.
I know, but just in case you...
No, we don't routinely do that. And most of the time they have seen an orthopedic surgeon, they've got a bone scanning done, they've got vitamin D scan, level, calcium level done, everything has been done. But we don't usually do that. Only thing is, if you have a marfanoid feces, in that case we do work up a little more from cardiac side.
Raising the bar is a little Elisaro skill, isn't it?
Yes, so that's why we do the crane lift. Yeah. So before that we just lift up, and the younger the age group, the more the pliable it is, and less pain we have.
Thank you.
Thank you, sir. Over to Dr. George. He'll be talking about chest wall reconstruction options.
Hi, good morning everyone. Yeah, slides it up. First of all, big thank you to Dr. Jayakumar and Vinita for having me over here. So I'm going to speak about chest wall reconstruction. I have a declaration to make. Probably I'm the only person in the hall who's not a cardiac surgeon. I'm a surgical oncologist who specializes only in thoracic surgery. Now, can you give me the other view where I can control the video? You're supposed to duplicate something. So we see chest wall tumors quite often, and based on their location and size, we have different solutions for them. They sometimes affect the sternum, sometimes the anterior chest wall, sometimes the posterior chest wall. The interesting thing is that most of the time, all of them require excision. The problem is not in the excision, it is actually in the reconstruction. So most often these tumors, I used to work in a general hospital, Tata Memorial. Most of the resections were done by JRs or the housemen. Then, because none of them ever have an immediate complication, I've seen only one post-operative death in probably 20 years. But they do land up with complications and the lives are miserable. So it needs a lot of attention when it comes to reconstruction. So it's not something to be looked down upon. The first thing is, how wide do we go when a tumor is like this is seen? So the classical teaching is that you need a 4 centimeter margin. Now this data is from Mayo Clinic and this is a 40-year-old paper. But unfortunately in India, when you see tumors like this, for instance, this is an osteosarcoma which came at the first and second rim. Getting a 4 centimeter margin is virtually impossible. So what you need to do is to get an adequate but a definitely negative margin. So how do you achieve it? You preserve as much of the local tissue as possible. For instance, this is a soft tissue sarcoma on the sternal surface. What you take off is the outer table of the sternum. That's adequate margin and that's good enough. It leaves the rigidity of the chest wall intact. Or something like this. This is a lymph node along the internal mammary, commonly seen in breast cancer. You take off half the sternum and reconstruct that half of the sternum with bone cement. So you preserve normal tissue as far as possible and achieve an adequate margin. So, avoid reconstruction as far as possible. That's the best way to do it when you can achieve an excision with good margins. Why reconstruct? It's a silly question. The chest wall protects the internal structures, provides rigidity, respiratory mechanics, everything. So essentially you need to repair it and repair it well. What are the factors which decide this? One, as I mentioned, is the size of the defect. If you have a large defect, you might have to find much more advanced techniques to repair it. The location is important. Anterior defects need more repair than posterior defects. So also pulmonary function. Some of them occur along with lung cancer where the chest wall is infiltrated, and when you remove it, if the lung function is poor and there is flailing of whatever chest wall you resected, then there is a problem. Also, often you find patients with osteomyelitis, in which case when you resect, repairing it is a problem because any kind of prosthetic material is likely to get infected and extruded. There are other considerations, so I'll expand on this one. The size of the defect. If it's a single rib, usually no reconstruction is required. If you have two ribs, or sometimes if it's something like second rib, where the second intercostal space is the largest space, when you excise, you definitely need some reconstruction. Probably, but a mesh would be enough. But when you have a defect which is more than 5 centimeters or 3 or more ribs are removed, then you need rigid reconstruction, and it gets trickier and trickier. Also, defects which, like I mentioned earlier, if you have anterior and lateral defects, always need reconstruction because the space is huge. But defects beneath the scapula probably can avoid any kind of reconstruction, but the scapula will cover the defect. Only thing you have to remember is along the 4th or 5th space, even if it's posterior, you need to reconstruct. If you leave it alone, I had patients in whom the tip of the scapula, when the patient abducts, gets trapped in the defect. So you have to be careful in that area. So first 3 ribs, you can probably avoid. 4th or 5th space, better to reconstruct. So size of the defect and location are important determinants of how you reconstruct a patient. There are other factors also, like compromised lung function. Patients who have a poor lung function, like an FE1 or DL2 is poor. Even the slightest amount of failing will cause type 1 failure. I lost one patient post a lung resection to failing, just simple flailing. So it's to be considered. Infected field, like I said, you have to use SL dermal matrix or porcine or bovine material. That's the best material available. And in a young child, it's a special case. You can't use rigid reconstruction. If you use a metal plate or cement, many of them end up with kyphosis or scoliosis, and this definitely should be avoided. Probably some bioprosthetic is the best way to go ahead. So this is the ideal reconstruction material. You will never find a material which matches all this criteria. That it should be rigid enough, it should be radiolucent, it should be malleable enough to allow reconstruction, sterile, and finally it should be inexpensive. I haven't yet encountered a material which meets all these criteria. All these are available commercially. The commonest ones which are put up there are methyl methacrylate, which is bone cement, which is used for bone reconstruction, and a polypropylene mesh. I used to work in a general hospital, so economics was one of the important determinants of what material should be used. Currently, we are using titanium meshes and plates stuff in the stratos and the metric system as well. But economics, again, finances are an important thing. So this is the simplest thing which you use. This is a polypropylene mesh or a polyene mesh. It's become very cheap. Stretch it taut, double layer over most defects. This will be good enough. But when you stretch it over more than a 3-rib defect, what happens is there is a certain amount of flapping and the contour of the chest wall is lost. But for small defects, less 2 ribs around, this is adequate. You could also, they're easily manipulated. You can mold it around. They found excellent scaffold. You can put a muscle flap and like an LD flap or a serratus over it, and the shape is well maintained. But it is insufficient for large defects. You could also use something like Gore-Tex, which is the one which is seen lower. It's more inert, but there are more seromas, and definitely it's much more expensive. Best part is if it's infected, at least it's easy to remove. A proline mesh, once it's integrated into the soft tissue, it's quite difficult to remove completely. And many patients follow up for years with small sinuses. Now it comes to rigid reconstruction. So there are many options available. Some of the options I've seen here, that's a strato system. Then you can use mesh and cement, and you can use a titanium mesh as well. Depends on the patient, whatever they can afford is what we place practically. The simplest is methyl methacrylate bone cement, excellent stability, it's inexpensive, but it's a hard material. Once it's formed and you mold it into a certain shape, it's difficult to manipulate. Then you have to chip the edges off or cut it off, and it's extremely difficult. And the rigidity itself causes pain. This is a short video of how the cement is made. It's made, you make the shape with a lint piece. That's a lint piece which mimics the shape of the defect, and you place the cement, mix it and place it. It's in a double fold of the mesh. So you suture the mesh to the edges of the soft tissue, you drill holes through the bone cement, and this is anchored to the ribs. It's quite rigid. You can maintain cosmesis if it's shaped correctly, but there is a degree of rigidity. And the main problem is in oncology is that it's completely opaque. You can't, an X-ray is impossible to detect lung lesions after you place a bone cement. So oncologically it's quite difficult. You need a CT scan to look at any recurrence in the chest. Currently the flavor of the season is titanium. So you have systems available from Stratos, Synthes. They are bars which you can stretch across the ribs. You have to screw them or you can crimp them into the adjoining ribs. They're inert, lightweight, MRI compatible. But when you look at the brochure, they always placed for bone rib fractures, and they are actually not meant to be used for chest wall excision. Simple reason is that the metal fatigue is a problem. There have been reports of titanium struts fracturing. So there is a long-term data coming out now after the initial wave around 8-10 years back that the complications are coming up, and technically it's not recommended for chest wall reconstruction. But for lack of a better solution, I am using this. So this is something, is a titanium mesh again. It's a very thin one which is placed over the chest wall. Again, 8 mm to 10 mm screws are placed into the rib, and it maintains the contour of the chest wall. And fortunately, this one is quite radiolucent. So what happens is, you see the X-ray over here, you can hardly see the titanium mesh. So it's easier to follow up patients also long term with X-rays. Any recurrence or lung metastasis can be easily picked up. And this is a video of the same patient, which I think we did it a couple of weeks back. And you can see that the chest wall movement is quite fine, the contour is maintained, and there is no flailing. So it is a good system, but we started using it 3-4 years back, so I really have no clue about what the long-term follow-up will be. You can do the same curvatures with bone cement as well. This is something which we have done. It's a sternal excision which we have done with and replacement bone cement. Again, the side-to-side curvature has to be maintained as well as the superior, and there's a curvature from superior to cranial caudal as well. Both can be maintained. This is over a long period, and she did well. But we have unfortunate episodes where they get displaced and they can come out, they protrude through the skin, it's a skin fistula. Then you take out the cement, the proline doesn't come out completely, they form a sinus. Then you place a mesh over it, and sometimes bioprosthetics as well. So displacement of cement over a long term is a problem. This is an increasing problem because cancer survivors are living longer. So you meet the complications later, 10 years later often. So this is a cosmetic problem. The far worse problem is when the mesh cement process actually falls inside. So they erode the lung, reach up to the bronchus, and some of them come with bronchopleural fistulae. So the thing is, sometimes you escape by taking out the cement completely, the mesh doesn't come out. And I've done up to pneumonectomies to repair the damage of such surgery which was done up to 8 or 10 years back. So the mesh displacement or cement displacement is a serious issue, and you tend to encounter them a long time after the initial surgery. So the more you follow up these surgeries, the complications actually mount up to 20 to 30%. This is a surgery which I had done after 15 years. So what you do is minimize rigid reconstruction. So something like this is a lower lateral defect which is infiltrating the 7th or 8th rib. Once you excise this rib, I avoided completely the reconstruction by hitching the diaphragm up, pulling up the diaphragm and switching it to the higher rib. So making the abdominal thoracic defect into an abdominal defect and replacing it with a mesh. And this is another picture of actually a mandibular excision with bilateral clavicular heads being excised. And we have replaced it with rolled up mesh. So hard reconstruction is avoided, the clavicular movement was maintained, and this probably minimized rigid reconstruction as far as possible. So if in future, if you find a sternal defect like this, would you do it with the age-old PMME or something else? This was what we attempted. So this is something which is done with our orthopedic surgeons. They are very good at prosthetics. It is 3D printed design. It's a modular design in which there is a sternal plate and the ribs are counted and shaped. So you can actually add the ribs to it as we excise it. So this required a bilateral 3-rib excision. So this is the thing in place. You can see the titanium sternum with the heart beating beneath and bilateral 3-ribs excision. Dr. Manish Agarwal, who is a gentleman who designed. And because the sternum, the joint between the sternum and the rib, it probably mimics the movement of the ribs as well when the patient is breathing. We have follow-up for almost 2 years. It's been uneventful. This is the immediate post-op CT. We did a CT just for academic reasons. The only issue is that this costs 2.5 lakhs, and that's quite a bit of money. The important thing, and this patient unfortunately had a complication immediately after surgery, and that's related to a simple thing. We forgot to put, we thought the skin cover was adequate. It was a thin rim of skin, and there was a small bit of necrosis. It got infected, and the patient spent a long time in the hospital. So soft tissue reconstruction is something which you should not ignore after placing a prosthesis. Whatever, you can directly suture, but if you feel the tissue is thin, and advance a muscle flap, latissimus dorsi, pectoralis major, serratus, there are enough muscle flaps in the surrounding area, advance them, make sure your prosthesis is covered. So in conclusion, the reconstruction begins with the excision. Do not do an overly aggressive excision. Adequate margins or a sensible negative margin is good enough. There is no randomized data which says that you have to achieve 4 centimeters. That's just historical data. Utilize every bit of surrounding tissue possible to make the defect smaller or make your reconstruction easier. Soft tissue cover is mandatory. Whatever process you feel, if it is not covered adequately with soft tissue, they are likely to get exposed and land up in bigger problems. If you have a doubt about flailing or anything, err on the side of reconstruction and use the appropriate material. Unfortunately, I am not able to guide you as to which is the perfect material. There is no perfect material for reconstruction. Pick one which one suits depending on the age, the extent of the resection, the location, and finally economics. And when in doubt, always go in for a rigid reconstruction. It will be functionally much better. Ultimately, no technique is better. Judgment is the key. Thank you very much. I'll be happy to take any questions.
Wonderful presentation, George. You have shown that sternum being replaced with a 3D printed metal piece.
Yes.
Do you routinely cover it with some pectoralis major flap? Because otherwise it is just under the skin, no? Will it erode?
So if it is a small lesion and that's apical skin and subcutaneous tissue, you don't need a muscle flap. But you're right, if the skin layer is thin, advance the pectoralis major. It's always safer to have a muscle cover over any prosthetic material.
So muscle cover, you routinely cover it, or you mobilize the pectoralis major?
Yes. Pectoralis, latissimus dorsi, serratus, we just advance it over whatever prosthetic material.
Okay. Any questions from the audience?
Yes, please.
Yeah, congratulations, Dr. George, for the excellent work that you are doing there. Because my wife is a plastic surgeon, she used to tell that about your work. And so one thing is, as you said, the material to support the chest, always we are worried. And about the soft tissue cover, something we did 2 cases in our centers. Like since they are working on the free flaps and microvascular anastomosis, in 2 cases after chest wall resection, we put a free flap on the chest wall, and the donor vessel were aorta and the right atrium. So the artery was anastomosed to the aorta, and the right atrium was, the vein was anastomosed to the right atrium. The flap survival was excellent. So that is something where, of course, cardiac surgeon can work with the plastic surgery people and get a...
Excellent. That's really good work. But normally we find a donor vessel from somewhere. So the extreme case what you've done is we have put a cephalic vein jump graft whenever we couldn't find the artery in the local. So we use free flaps for cover. And usually it's the internal mammary or the epigastric which we take. And if it's not achievable and it's further off, we usually jump graft, probably cephalic vein, and take it to somewhere else. Never place it in the aorta directly, although it can be explored. Yes, please.
Very interesting, Dr. George. I just want to ask you whether you confirm the histopathological factor before doing sternal construction, if it is a sternal cartilage tumor of the manubrium or upper sternum, where if you do a transdermal true cut or biopsy, what's going to happen is there's going to be implantation, and then it might end up in skin grafting, etc. The same problem if it's a lateral chest wall. So when you're sure that 90% of manubrium tumors, well, chondrosarcoma or whatever, would you straight away excise it with 3 costal cartilages on either side and the scalenus anterior, etc., and go for a repair?
So, excellent question. If the diagnosis is radiologically obvious, so the characteristic features of a chondrosarcoma, no biopsy is required. But there are certain tumors which are confusing, like a peripheral neuroectodermal tumor, where chemotherapy is the primary treatment, in which case I would do a biopsy. The thing is to site the biopsy correctly so that it comes in the incision. If it's sited in a different place, it becomes a contaminated wound. That's point number one. Secondly, about the frozen section, you can get a frozen section opinion on soft tissue margins, but bone, you cannot get a frozen section margin.
Yeah.
So what you do is an MRI. The MRI will tell you how much of the bone is infiltrated, and you go by the MRI for planning your excision. That's how I would go about it.
Okay.
If you had to go back into the chest for fixing something in the heart or for fixing something in the lungs, how do you do it? Number one. Number two, you have had, you said the boy spent quite a long time because of sinus infection.
Yes.
Now, in that case, when would you consider to remove the processes or sterilize?
Yes. So we had instances in which the infection could not be controlled. We tried giving wound washes, and if you're desperate and it doesn't happen 3-4 times, we just take it out and provide put a SLR Delma matrix, or which is another option. Now, I must confess, I am a surgical oncologist. I deal with cancer. None of my patients live long enough for a second intervention, except if there is a problem. So I never had a patient who I had to go in for a bypass or anything of that. So it doesn't happen.
No, basically what happens is you have patients who come with sternal agenesis.
Yes.
Right? In that situation, you can actually bring muscle flaps together
Yes.
and close it, but maybe this could also be another option.
It is an option. But in an infected field, bioprosthetic is a much more attractive. Most often cardiac surgeons send patients to us for two reasons. One, when the sternum gets really damaged, they want us to repair it. Then they call the thoracic surgeon, come on, help it. And second time is when there is chylothorax, which happens frequently after a bypass. We do a lot of thoracoscopic clipping because that's the best thing to do.
George, good presentation. One thing I wanted to ask is that can we use this iliac crest for bone reconstruction? Because orthopedicians use that for some procedures.
So, iliac crest by grafts have been used for replace the maxilla and for this one. Not required is what I would say. It's a painful thing. So I had seen patients with plastic surgeon taking iliac grafts. It's painful here and painful here. Let's avoid the pain in one area, and it's difficult to shape the bone in that particular fashion. So we don't have an ideal solution to any of this. So it's virtually everything is a compromise when you're reconstructing the chest wall.
Okay, thank you.
Assuming that Ewing's is a non-surgical disease, how would you exclude that before going in for an excision?
So Ewing's is a surgical disease. Only surgery is an adjuvant. Virtually every chest wall tumor's primary treatment is surgery. But in Ewing's sarcoma or a PNET, the primary treatment is chemotherapy, which is almost 9 cycles. You add surgery to the chemotherapy or radiation to it. So it's the local control of a systemic disease. That's how we look at it.
Okay, thank you, George.
you
Wonderful
very much.
presentation, wonderful discussion. Now we'll move on to the fourth topic of the session, how to establish a robotic assisted thoracic surgery program by Dr. Subramanian.
Afternoon, everybody. So I'd like to thank Dr. Jayakumar sir and Vinita for giving me an opportunity to present the topic of how to set up a...
The light and sound people, excuse me, this monitor is not showing anything. Continue.
Is it okay? Yes. I'll be presenting on how to set up a successful robotic program. Now, so we all know that minimally invasive thoracic surgery, especially VATS or RATS, is an accepted surgical modality now. With a number of advantages we all know about, like shorter length of hospital stay or lower post-operative complications, less post-operative pain, and faster return to preoperative functional state of activity. Now, VATS has clearly proved its clinical and oncological efficiency, especially in multiportal and uniportal routes. Still, we find robotics invading our specialty with all these newer robots. Now, last year, around 4 to 5 newer robots have been introduced. So, why is it that in spite of us having a proper VATS set of wise, why are we moving into robotics? Now, these are some of the technical and technological advances that are available in robotics, which are not available in VATS, like the enhanced visualization. We find that robotics gives you a 3D visualization with 10x magnification, which definitely is not available in VATS. We have depth perception in robotics, which is pretty important when you're looping vascular structures. Importantly is the operating surgeon who's controlling the camera in robotics, unlike in VATS, where it is your junior who is controlling the camera. You have an extra third arm which can be used as a second assistant and also to control bleeding. You have importantly articulating instruments that actually mimics the movements of your hands, and the ports are slightly smaller at 8 when compared to the VATS ports. Now, as regards specimen retrieval, you have supra-diaphragmatic retrieval port, where you can remove larger specimens compared to the intercostal spaces, which are pretty narrow, and we'll find it difficult to remove large specimens. So, basically here, robotics facilitates surgeons without advanced vasolaparoscopic skills to perform complex surgeries with short or limited training. So how limited is the training? Is there a learning curve for a robotic lobectomy? So here we have a paper from 2021 where a single surgeon learning curve and outcomes are compared for the first 75 VATS cases he performed and the first 75 RATS cases he performed, and they found that the conversion to thoracotomy is significantly lower in the robotic group, although the operation time, length of stay, and the post-operative complications are all the same. Now, the proficiency attained for a VATS lobectomy was around 53 cases. It was slightly lower at 45 when we do a robotic lobectomy. Now, the clinical and cost effectiveness comparison. Now, earlier at the heart of robotic programs, we kept hearing that the cost of robotics is pretty high, but now when we go on to robotic programs where they do larger numbers, the experience is more, multi-specialties are moving into robotics, we find that the cost for robotics is almost similar to VATS. Now, the length of stay surely is lower. Robotics was around 3.8 days, while in robotics and VATS, while open was around 5.8 days. And the costs significantly now, they are coming to a conclusion that costs are pretty much the same. Now, is it a reproducible or trainable technology? Now, we know that VATS is pretty surgeon-centered. Now, particular surgeon may be an excellent VATS surgeon, but it cannot be reproduced by all, and that's exactly why we have only around 30% lobectomies being performed by VATS even now in the US. So robotic lobectomies have been found to be more trainable because you have a training console available, and then this is a paper from the Surfolio group where they have done around 520 robotic lobectomies for 5 years. They train general surgery and cardiothoracic residents to do the robotic lobectomies based on a step-wise time train chart, and they found that the operative outcomes were similar, whether it be done by residents or the consultants. The intra blood loss, the number of lymph nodes, median length of stay, major morbidity were all the same. Now, the operative time was high in the initial cases, but as the residents started doing more and more, they found that the time decreased, the conversion to thoracotomy decreased from 15 to 22.5%, and major vascular injury decreased from 3 to 0%. So robotic lobectomy can, in fact, be taught to residents without compromising patient outcomes. So that's exactly why you should be looking to set up a robotic program, because in the next 10 years you may be seeing more robotics than VATS or laparoscopy. So how do you go on to credential surgeon who wants to start a robotic program? Now we have the Da Vinci credential protocol here, which includes phase 1, 2, 3, 4 and 5. So I'll be explaining that based on our experience. We also follow the standard pathway, where initially the surgeon works on the robotic simulator to clock around 30 hours. Then they do an online module that explains the mechanics of the robots, the gears, the levers, and how you actually use a robot. And then you take an online exam where you have to attain around 80% scores. Now the porcine, human and cadaveric training is done later, and then you go for an observation stay in for around a month, and then you perform your first case, ideally within 2 weeks of credentialing. So it's important to train your team who is helping you. Robotics is a team game where the surgeon is at the console and he requires a proper team to assist him at the table. So in our unit, what we did was 3 scrub nurses who had prior VATS experience were chosen to assist all the robotic thoracic cases. Now in the initial 3 months, the nurses were asked to scrub in with other specialties like gynecology or surgical oncology, who already had an established robotic program. All the nurses were mandatorily asked to complete the online module, and it was they were mandatorily asked to stay for all the robotic cases. The team was maintained. Now we went on to perform the first robotic surgery in Kerala in 2016, and it was a right upper lobe bulectomy with an operative time of around 174 minutes. Now from then on, we have gone on to do around 231 robotic surgeries, predominantly being lobectomies, and followed by mediastinal tumors, thymectomies and bulectomies. Now, when we start out of a robotic program, we don't technically go straight into the level 3 operations. We start with the level 1 operations, like resection of posterior mediastinal masses or a lymph node removal or a bed resection. Now, these may be performed by VATS too, but in the initial stage, it is reasonable to use these simpler cases to train you and your team on robotics before moving on to level 2 procedures like a thymectomy, like a diaphragmatic plication. And to the higher, more complex procedures like a segmentectomy, lobectomy, or a pulmonary sleeve resection. Now we did our trends of cases in the initial 50 cases, and then second 50 cases, where we found that we were doing more lobes toward the second half. So if you can see, the first 50 had only 8 lobes. We had 20 lobectomies in the second. So it's always important to start slow, do some simpler procedures, so you and your team gets oriented to the procedure, and the team coordination will be far better before attempting more complex procedures. Now, what are the specific advantages robots provide in specific situations? Now, thymectomy is a situation where I would really prefer to do a robotic thymectomy than a VATS thymectomy. Now here you have a 10x magnification with 3D visualization, makes visualization of the frenulum be pretty clear. You have pretty clear herbae pressure cortex where you can go really close to your frenulum. I don't think we'll be able to go so close as far as VATS is concerned. Now articulation robotic instruments is what you're seeing now. You are working to take these cervical horns and you're working high up in the cervical area. So going into such an unfined space with that enhanced visualization and the articulation of the instruments is what makes a maximal thymectomy possible, which is pretty important when you do a myasthenic. Now you can see that visualization of the left phrenic nerve is also pretty clear, and we do robotics, and that's the post-op scars that we produce in the patient. So thymectomy is one situation where a robot definitely has a definite advantage over VATS. Now the second situation, there's a mediastinal tumor right at the apex of the chest there, and you can see it's virtually jammed between your superior vena cava and it's overlying your subclavian artery. Now, so Robert with its easier reach and visualization provides an easier access to tumors in such areas. Especially in the apex, you have the tremor filtering mechanism. So your instruments filter the instrument tremor is definitely filtered when compared to VATS, and that's why you can go really close and be confident in taking tumors of critical structures like the subclavian artery or the superior vena cava. So these are situations where surgeon comfort in this surgery directly translates to safety as far as the patient is concerned. Now another situation where I feel robot adds a lot of value. We saw a sleeve resection being shown by Sri Krishna sir earlier. So suturing capability of the robot. So here is another situation where we are left main bronchus carcinoma where a sleeve resection is being done. We find that the suturing capability of the robot is far superior to the VATS. So here a sleeve section requires a very skilled VATS operator. Robot allows a less skilled operator to do a sleeve. So that's exactly the huge advantage of robotics. Tremor filtration plus instrument articulation allowing you to do precise suturing in such situations. Now, as a giant pulla, so situations where you have a large tumor or a cyst, we see that the camera control here is under the surgeon. So he will be able to do a more efficient operation, especially when you have a large tumor. You have very little space to move the camera around. Here the robot also helps you in localizing the instruments, especially when you have a large tumor. That's not possible in VATS. So supradiaphragmatic removal of these large specimens are another advantage, because in VATS you take it out through the rib spaces. Newer additions like staplers. Earlier we had the first assistant doing the stapling. So the most critical step in a lobectomy used to be done by either for first assistant, but now with robotic staplers, the stapling is handled by the surgeon himself. So it decreases the operating time, lesser coordination is required between the surgeon and the table assistant. Now, because of lack of time, I'll be skipping a few slides. So here we see robotic colectomies. Please concentrate on the age and also the mean operating time. You can find this pretty much almost similar to our open work. Here the age range is around 82 years and mean operating time is around 3.5 hours. Robotic mediastinal tumor excisions, you can see a range of around 8.5 centimeters being handled. And lobectomies where we do it in around 4 hours. So as we go on to do more and more number of cases, we find that the efficiency goes way up to come closer to the open thoracotomy timings. Now, median length of operative stay is around 4 days for routine level 2 procedures and 5 for lobectomies. Unconversions we had around 3.8%, which is far lower when you compare to VATS, and we had no conversions for uncontrolled bleeding. And the reasons for conversions mainly usually are technical difficulties. If we find that we are not proceeding, we tend to convert them. No mortality, morbidity too is pretty low, and costs usually they are around 25 to 30% higher in India when compared to the Western countries. But as soon as we see more case numbers across specialties, acceptance across centers, and by reducing our operating time with improved technology, we really feel we can do it at a lower cost. But won't you pay more for scars that look like that in a year? So future of robotics is pretty amazing. We are going to see a lot of uniportal robots where you're going through a 2 centimeter port with a camera and 3 instruments. Uniportal subsifoid approach where you can completely eliminate intercostal neuralgia. So here you are seeing the Chinese robot here on the left side, which has a wide angle of approach. That's probably coming into the market in a year. So in short, robotics in thoracic surgery is here to stay. We are pushing the boundaries even further with robotics. The learning curve for robotics is not steep, especially if it's a consistent team doing procedures at a regular frequency. The introduction of newer technology is going to make it far more easier to do than the VATS, and I really feel it's time to go robotics. Thank you so much.
Thank you, Dr. Balasubramaniam. It was an excellent presentation as to how to set up a robotic VATS program in a hospital. I think we are running too short of time. We have one more session to go. So, if any sessions from the floor, any questions from the floor, 1 or 2 questions can be allowed. Then we'll move on.
Hi, this is the question of which system to follow. Right, there are 2 systems available in India right now commonly. One is Da Vinci. The XI will cost about 18 crores, and there is the SSI Mantra, which costs a third of the price. Yeah. Any comparison between, if you were to go into new, what would you choose?
So you see, Da Vinci XI is it has been in the market for around 10 years. All the other robots are pretty new, so they don't have a background. You can't do a background check on them. I would feel it all depends on what your hospital can afford. So Da Vinci XI costs around 20 crores, while the Mantra, which is an Indian robot, is I think it's around 8. So Mantra is more tuned to do cardiac work, while the Da Vinci is a more general purpose robot.
What I meant was that, what do you lose in capability? Like if you have any experience, obviously there's a trade-off between features versus cost, right? So what do you lose by choosing a cheaper robot?
So my experience has been with only with the Da Vinci. I think Arlong has experience with the Indian robot.
We are having both the Da Vinci and Mantra system. Our urology department is the one which basically is driving the Mantra system. So the urologists, the GI surgeons are very, very happy with it. That there are still, intricacies are there. Da Vinci has got a lot of movement. It's like you can drive a car. It's like driving a car, reading a book, like you're seeing like this. And in Da Vinci, you can basically sit down, lie down and operate, because the camera is, it's like looking down, or you can look up. So it has got all those things. It's like a Formula car. You can drive this way all around, and like you can see from up, from down. But other robots still don't have that capability of basically like upward viewing, lower viewing. It's like, just like a joke, Sardar operating from below. You know that, no? So it's like that. And the drive, like the formula you see, like turning and all, that is still lacking.
Okay.
So Da Vinci, still now, and if you are starting with Da Vinci, you will find other robots difficult. But if you are starting straight to Mantra, you will definitely find it amazing.
Thank you very much, Dr. Balasubramaniam, once again. So I think we'll conclude this session so that we'll have one more session. So thank you very much.
Thank you.
Thank you, panelists and speakers, for those very impressive and incredible talks on thoracic surgery. Coming to the last session, cardiac surgery, being the most dynamic field, has evolved through ages and has astonished everyone with new innovations. It becomes very essential to have a holistic perception of the complete journey by remembering and anchoring the basics as well as accepting innovations and discovering with ways to implement them on a daily basis.
Now may I invite the chairpersons on to the stage. Dr. Kiran Gopal, Additional Professor, CVTS, Amrita Institute of Medical Sciences, Kochi, Kerala. Dr. KK Pradeep, Senior Consultant, CVTS, Lourdes Hospital, Kochi, Kerala. Dr. Shiva Prasad V, Associate Professor, CVTS, Government Medical College, Calicut, Kerala.
Good morning. Since we are running for behind time, we'll start the session immediately. Could we have Anil Tendulkar sir to start his talk on safe sternal closure techniques? Because we are running far short of time, we might be restricting questions also.
Good morning, everybody. Really starting with the basics. First confession that I prepared this topic only recently, 7 years back. And during my entire tenure as a professor and head of the department, I never learned about sternal closure. It was all transformed from seniors to us and me to my juniors, sternal closure. But this I learned because I prepared a program for Johnson & Johnson about basic science of sternal closure. So first, for that we have to learn the anatomy of sternum. We all think manubrium is the most important structure. In fact, entire sternal mobility is because of rib attachment, and manubrium has the least number of ribs attached, only 1.5. So chance of manubrium moving in following sternotomy is the least. While if you go to see the lower part, how can I use the pointer? Yeah, I can see that. While if you see the lower part, the costal cartilages, the conjoined costal cartilages apply a joint force. So the lower part of the sternum has got a more number of rib attachment. And so if the ribs are going to decide the sternal movement, the lower half of the sternum moves more. The sternum consists of two compact bones and a cancellous bone in the center. And nowadays, if you are going to use the screw, you must have an adequate posterior table. Posterior table should be adequate. And number two, from holding the circlage wires, the lateral table also should be good for sternum to heal well. The blood supply to the sternum starts from the side, and in the center, the blood vessels don't cross the center. That's the importance of opening the sternum right in the center. Same thing. Now, sternal blood supply has been extensively studied. So most of the MCA students write down just one line, sternum is supplied by internal mammary artery. Full stop. Sternal blood supply is over. So actually sternum is supplied by 6 various types of arteries. The top 3 which you see are non-collateral branches, while the bottom 3 which you see are called collateral branches. Unfortunately, this branch distribution is not equal. As you can see, the distribution of non-collateral to collateral is 5:2 per hemisternum. So it is more chance of having non-collateral blood supply in the sternum. And amongst these branches, this 5 to 7, it pertains to this 5, to this 2, to this 7, and to this 3, to this 2, to this 1. So that all shows that the blood supply to the sternum is very precarious, and more blood supply because of pectoralis major muscle in the 2nd, 3rd and 4th space, and 35% of the cases there is no collateral branches in the adjoining part. Another point you must know that branch lay around 5 millimeter from the sternal edge in 44% of the cases. So when you pass a wire around the sternum, try to be within 5 millimeter, otherwise you are going to strangulate the mammary artery while passing the wire around the sternum. Simple question, what happens to the sternal blood supply after harvesting mammary artery? And nowadays, because of various technologies available, you can actually study the sternal healing and sternal blood supply. In the olden days, we used to find out sternal healing just by pressing the two sides of the wall and say, good sternal healing. Now no more, you can actually do CT scan, ultrasonography and find out the sternal movement. So here you have got a picture of sternal CT scan done, which shows that total lack of blood supply over here, but it regains all the blood supply by 1 week. Muscle attachment, there is no muscle right in the center. This is what the resident should keep in mind while doing sternotomy, that moment you come across any muscle while cutting the pre-sternal tissue, remember you are entering a wrong plane. Now, as we said, that ribs are responsible for movement. There are 3 movements of the sternum. One is outward, another is forward and backward, and third is upward and downwards. So longitudinal shear, transverse shear and lateral shear. And these are the direction, and mind you, all these movements are because of normal breathing. You don't require excessive coughing or sneezing, just normal breathing. And the longitudinal movement, this one which you see over here, is because of walking or trying to get up from the bed. And we are very proud that my patient starts walking the 2nd day or 1st day evening, my patient starts walking. So remember, you are walking, you are talking, you are coughing, sneezing, deep breathing, all is going to affect your sternal movement. Now on cadaver, sternal force is studied, and it is up to 1500 Newton. 10 Newton is 1 kilogram of weight by gravity. So when you sneeze or cough, you generate a force of, for a fraction of a second, of 1500 Newton. And the best sternum in the world can withstand cut through between 390 to 800 Newton. So the wire which you put, you must ensure that it is not subjected to more than 800 Newton force. So on cadaver specimen, people studied the sternal movement, and as expected from the knowledge of anatomy, all the 3 movements were studied, and as you can make out, the maximum movement was in the lower, maximum movement was in the lower half of the sternum and least movement was in the manubrium. The same cadaver were subjected to ventilation, and again same was found, that the maximum movement is in the lower half of the sternum and minimum movement in the manubrium. So the first lesson all of us must learn that more wires should be put in the lower part. This cartoon is by me. So gone are the days when my seniors used to tell me 2 for the manubrium and 4 for the body. Make it 6. No. If you want to put 6 wires, then better put 2 on the upper part, and lower part should have more wires. This is not just theoretical. People again did model study and they inserted an extra wire. So these are the two without a lower wire, but moment they put a wire extra in the lower part, you can see the movement shift straight away reduce. So remember, the lesson is put more wires in the lower part. Coming back to physics, to learn the second important lesson this is Laplace law. Tension on the wall of a cylinder is directly proportional to the radius multiplied by length multiplied by pressure inside the cylinder. So if you assume that radius of the chest wall, assume chest wall as a cylinder, so the radius of the chest on an average is 15 centimeter, length of the chest is around 25 centimeter, and if you generate during breathing, coughing, a pressure of 40 kilopascal, then you are going to generate 150 kilo of tension. So what lesson you learn? That sternal wiring is far more important when the radius is in the lower half. The sternum is like a cone. The chest wall is like a cone. So the radius is more in the lower half. So you must develop more tension in the lower half. So if you have got a patient with a long length, that patient is going to generate more tension. So you must put more wires. Then patients who generate more pressure, like those who are cougher, COPD, lower respiratory tract infection, smokers, try to insert more wires. And relative more tension in osteoporotic patients, elderly patients, redo patients, you insert more wire. So when the chest wall generates a pressure of 1500 Newton, if you put one wire, that single wire will try to withstand a pressure of distracting force of 1500. Put 2 wires, 750. Put 5 wires, 300 each. Put 10 wires, 150 each. So the lesson number 2 is put more wires. So don't try to just make it a rule that I put 5 wires and 6 wires. Put more wires so the entire pressure will be distributed over all the wires. As a result of this, chance of cut through will decrease. This is my friend Sandeep Honekari. I remembered him yesterday for his technique of gastroepiploic. This is chest he closes, he puts 12 wires. And believe me, patients are really painless. Another advantage of putting more wires, that patients are really painless. This photograph is not taken for photography's sake. This is real, actual amount of wires he puts. Coming to the third part of physics is the stress and strain curve. The bone has to be made rigid. So here which you see, this is the strain, this is the pressure applied on the sternum, and this is the stress. How much Newton? So initially all the bones all the bones are in elastic zone. They bend a little and come back to their original shape when the pressure is released. After some time, beyond a particular time, this relation changes. They bend very easily. And the third stage is a plastic stage where once the bone bends, it doesn't come back to its original shape. So knowing this, we must ensure that we restore back the rigidity of the sternum. In the various materials that we have got, one important part of metal is metal fatigue. If a metal is subjected to repeated stress, however lower stress, the metal gets fatigued. So all our sternal wires are subjected to repeated pressure of coughing and sneezing. So good chance that they may undergo fatigue. Have you kept my timer on 15 minutes? 15 minutes? Huh? 30 minutes. Just check. Huh? What happened? I was surprised. Suddenly I saw 6 minutes. So metal fatigue is a very dangerous phenomenon. So moment the metal loses its power, its physical capacity, the wire which was tight on operation table, after few days, few weeks, it will start losing its grip. So you must have a quality of material which retains it, which prevents it from undergoing fatigue very early. So various types of materials were studied to find out in an accelerated machine. The materials were studied and it was found that steel wire is the best material. Of course, this was not a time when various new sternal bands came into picture. This article is of 2001. So before that they must have conducted study. But they studied all variety types of materials and the best material found was steel wire and steel bands. Now these are the standard guideline principles of any internal fixation. I refuse to read this word. So all it means that you must ensure restoration of anatomical relationship, stable fixation, preservation of blood supply and early and safe mobilization. So bone healing occurs in 4 stages. So as I told you, nowadays because of CT scan, people have studied sternal healing on CT scan and they found this, that no healing takes place in first 3 months and only 50% of the cases have got a complete healing in 6 months. So this is very important in prescribing persons to go back to work, to start doing their original physical activity. This thing has to be kept in mind. So the method of sternal repair has to be is of great importance from long-term stability. And here as you see, comparison of various sternal healing. So it was found, people even did CT scan and graded the quality of healing to form A, B, C, D, E, F, and they decided whether the healing has taken place properly or not. Even ultrasound has been used to study sternal bone healing. So it has most important that the sternal healing, what we feel, the skin heals in 15 days, but remember only 50% of the sternum heal in 6 months. Now come to the concept of band. Band, any broad structure, results in distribution of pressure over a wider area. So this is the reason why if you want to cut any sharp structure, you don't hold a blade horizontal like this. This kind of blade will not pass even through butter. Even this so-called illiterate people know that if they want to distribute the pressure, they must have a broader package under the weight. The famous manja, cutting the neck, is always by a very fine thread, is never with a thick rope. So, most important is, if you have got pressure distribution, you must have a broader, wider sternal wire or sternal band. Most of the sternal bands are 4 millimeter plus, while most of the wires are 1 millimeter less than 1 millimeter. So distribution of pressure over 4 times. So even if you generate a pressure of 150 Newton, it is distributed over 4 times wider area. So most important is to choose appropriate size wire. Don't make it a rule that adult patient 5 number and children 1 number. Don't make such a rule. Usual formula is weight divided by 10 should be the amount, the size of the wire you choose. Another concept is the sternal fit. If you pass a band or a wire which is very rigid, you can see in this diagram, it touches only 4 corners. This is not going to help you in sternal healing. The wire, the band should be gripping the sternum all around. Then only the healing will be successful and complete. So, lesson number 3 or 4, I don't know, perhaps they are counting. The lesson number 3 or 4 learned is a wire and a band which are using should be malleable and elastic. Should be fitting around the sternum absolutely millimeter to millimeter, not just touching the sternum at 4 corners. Fortunately or unfortunately, there is no definition of bad sternum or high risk sternum. This is the list I have prepared myself by going through these articles regarding high risk sternotomies, and I myself divided into 3: patient related factor, procedure related factor, and disease related factors. The blue one is the patient related factors. The red ones are the surgery related factors. Most important is okay. So remember, that is the peculiarity of cardiac surgeons. They remove lima, and then they want the sternum to heal very, very well. And they start crying that my sternum is not healing well. So what are the factors which we contribute to poor sternal healing? One is opening off center, sternal retractor resulting in sternal fracture, blood supply related injuries right from passing wire and mammary harvesting. Wax prevents sternal healing, and periosteal cauterization. Entire blood supply of sternum is through periosteum. So all these things are responsible. People have studied bone wax and they found that the number of bacteria needed to initiate an infection is reduced by factor of 10,000. Reduced. So more chance of sternum getting infected. Number 2, it acts like a barrier for osteoblasts to move and heal. So as far as possible, avoid using wax. So here you have got what should be the qualities of a sternal closing material. And as I told you, cardiac surgeons are like I don't know whom. At the time of marriage, they think about divorce. Since yesterday we are hearing, at the time of wall implantation, we are thinking of what will happen, so TAVI should be done. So time of implantation, we are thinking of degeneration. So cardiac surgeons are the only people in the world who think about removing the sternal material at the time of implantation. So the material which you use has to be explantable at a very, very short notice for giving open chest massage. So various materials are used. Here you have got a full list of various materials. We'll quickly go through. So if single wire is likely to cut through, people are using double wire, and one company has come with a loop wire, and you can put it in a variety of methods. Simple peristernal wire has been found to be the best method of holding the sternum together. Simple peristernal wiring. Here you have got a variety of butterfly technique. You just talk about it and you have got the sternal closure techniques. Then comes the second group, which is a zip fix cable system, and zip fix is a material called polyether ketone. So PEEK, the material is called PEEK. It is in market for last more than 10 years. As usual, cardiac surgeons are the last to start using it. Advantage over metal bands that it can easily be cut with a Mayo's scissor, and it can withstand a stretching of 300 Newton pressure. That much is the strength of that zip fix. Clinical studies have been done, but unfortunately clinical studies show no real advantage of zip fix over standard sternal wire technique. Zip fix can be used by two basic methods. To your right is only zip fix, and to your left is zip fix with sternal wire, one in the top, one at the bottom. So these are the clinical studies. This is the last study, 2019 last study, and they found only the pain had reduced in the case. Then we have got rigid plates. These plates are very costly, and as I told you, the screw should reach the posterior table, and variety of plates are now in the market, but the cost is very prohibitive. Then this is the sternal tanlon device, similar to your bags. You just press it and the sternal closure takes place. So you have got single talon, double talon. Then thermoreactive clips are available. So variety of techniques have been used for closure of the sternum. So lessons learned from all the science is place more wires or bands according to patient profile. More wires, more bands should be in the lower half of the sternum. Broader the material reduces the chance of cut through. The material should grip the sternum rather than touching the sternum at four corners. And measured approximation, if possible, and I'm told it is possible with zip fix system, you can have a measured approximation, so that is better. And during sternotomy, remember, and during IMA harvesting, remember, this sternum is going to heal. God created us for sternal healing, not for cardiac surgeon to use it as a conduit. Just for MCS students, just half a minute, just topics for your short notes: open chest and delayed sternal closure, vacuum assisted sternal closure, and adhesive enhanced sternal closure. These are the topics which you must read for your examination. Thank you very much for a real patient hearing. I could see the last rows not talking with each other, so I am really thankful to them. Next time I think the organizers should have only the last row.
Thank you very much, sir, for that very enlightening talk about basic surgical strategies. Just one question about that sternal band. We find it very easy to apply actually the sternal band. Have you found any disadvantage for the sternal band compared to the wire?
When you tighten the sternal band, there is a little that the place where it gets slotted out can be easily felt. And many patients complain about. And number 2 question is, when you re-explore for bleeding, second time what are you going to put? Because it's first time itself it is of cost. But this sternal band comes with the needle. Zip-Fix comes with the needle. And already there is a request to the company to, rather than supplying 6 or 8 bands, if they start supplying 1 band or 2 bands, that will be, the use will be much more.
And then you also said more wires are better. What is your recommended number of wires? You said more wires better. What is
more wires means you find a space, put a wire.
So how many wires would you recommend in one patient?
A minimum 10.
Sir, is there any difference between the figure of 8 and single sternal wire?
As I told you, as gripping is more important, the simple wire just pass once gives you a better grip as against figure of 8. So this comparison of figure of 8 and single wire, peristernal, because peristernal gives a broader width of the sternum, while transsternal gives a less width of the sternum. Like a cut through, chance of cut through is less.
Maybe we can probably take one question from the floor.
Sir, thank you. One question, sir. Upper.
Sir, Sir, look at me.
Yeah. Upper vertical partial sternotomy, is it less sound than full sternotomy? Because it might lead to asymmetrical, inappropriate retraction.
No idea.
You don't think so?
But it should be treated like a fracture, and should be same principle of fracture it should be treated.
Thank you very much, sir. If there is no more questions, thank you.
Somebody.
Wire is broken, sir. Like, what would you recommend in those cases? Or if one side sternotomy is little one side, suppose junior did the sternotomy is little one side.
So keep in mind that
still do simple wire.
The other broader sternum from midline till at margin is going to be avascular. So you support the healing for a longer period with a better quality material. A material which will not cut through, material will not undergo fatigue. So normal other sternums heal in 6 months. This may take even more time to heal.
So in these patients again more wires.
Yeah.
And then another thing is if wire is cut through.
If we could carry the questions later on, maybe we're running really short of time. Thank you very much.
Thank you, sir. Now we'll call Dr. Idris. From the basics, we'll go to the future. Dr. Idris will talk about a frozen elephant trunk, the Indian scenario.
Good afternoon to all. So I thank Dr. Jayakumar sir and the organizing team for giving me this opportunity. Slide. So the topic for is frozen elephant trunk and the Indian scenario. So over the 4 decades, frozen elephant trunk has evolved over the years, ever since Hans Bros introduced in 1982, and has come a long way along. And the indications has been expanded. Initially it was only aneurysms, it has gone up to chronic type B dissections, then it gone up to acute dissections, and even the residual type B dissections have also been included. This frozen elephant trunk has been very helpful for remodeling of the aorta. If you could see here, if you could see the true lumen and the false lumen is over. The true lumen and the false lumen are there. When you place a stent over them, the true lumen expands and the false lumen undergoes thrombosis, and the positive remodeling is much better when we use a frozen elephant trunk. So this has been shown in multiple literatures where the remodeling is over 90% and when we use a frozen elephant trunk in type B aortic dissections and also the aneurysms. So initially these frozen elephant trunk was thought as an industry driven product, and it was not taken as much, and slowly as literature and evidence start emerging, there are multiple advantages in frozen elephant trunk as compared to a limited resection, limited arch resections. So these are the different hybrid processes available across the globe: Cronus, Evita, Thoraflex and J grafts. Only the Evita and Thoraflex is available in India, other two are not available in India. So these are available from 2018, commercially available in India. Prior to that, there was no non-availability of these frozen elephant trunk grafts. So that point of time, what we did was actually we converted the regular theatre into, borrowed some idea from the orthopedic colleagues, used the fluoroscopy and the fluoroscopic machine and converted them a sort of hybrid theatre and started using a frozen elephant trunk that point of time, where we deployed the endografts, after going on TCA, the TVAR grafts we deployed antegradely, which are supposed to be deployed retrogradely. We deployed them antegradely and then then used an arch graft to reconstruct the aortic arch. So this was prior to 2018, which we did, and we published our series in our journal, in a small series that time. And then right after 2018, when the hybrid process started available, so the Evita or the hybrid, the Thoraflex are available, the surgery became much easier. So the entire process takes only 25 minutes to maximum around 35 minutes. The frozen elephant trunk hybrid process can be deployed into the descending thoracic aorta. There is a good cuff in all these hybrid processes where we can suture them with much easier. The entire TCA times comes down significantly, where in the earlier days it used to be for 50 minutes to 1 hour. It now comes down significantly to around 25 to 30 minutes time. And the hemostasis at the distal anastomosis is also much better, much better. This is even more pronounced in the acute dissections, where that hemostasis area, where the tissues are even more poorer quality, the hemostasis are much better. We published the first frozen elephant trunk in India for acute dissection in 2020. And then later the Evita grafts also came into evoke in 2020, and we deployed it during the COVID time. So these are the different elephant trunks which has been implanted across the in our center. We went on to describe the most difficult part in the frozen elephant trunk is actually achieving the subclavian artery. The subclavian artery is the deepest structure which is goes deep, very deep, and the harvesting that and doing anastomosis becomes very difficult, and it is very important that the subclavian artery is reimplanted, otherwise there high incidence of paraplegia is there. So we developed a technique where we harvest, where we divide the sternal edge of the sternocleidomastoid muscle and get a better exposure of the subclavian artery. You could see that once this sternal edge, once this sternal head of the sternocleidomastoid is divided, you could see that all the three vessels are very visible. That is the subclavian artery which we hooked up. So all the three vessels are very much visible, and then we can reconstruct the arch in a much better way. And the sizing of this frozen elephant trunk is very important, and these are the only two papers in literature which talks about the sizing, and we have described a consensus document from the different surgeons across the globe, and we published them during the COVID period, and which has been followed in multiple centers across the globe, the sizing method. We have some special challenges in Indian scenario as compared to the Western world, and where we do the frozen elephant trunk. So if you see the public sector and the private sector is compared to here, when you see the rural population and the urban population, the urban population is only 35% as compared to the rural population in India, where it's around 65%. This is also reflected in the healthcare system, where almost inpatient of the urban population is almost 56 as compared to the rural is 44. I mean the private sector, the private and the public sectors. The private sectors harbors a lot of patients, and the OP patients are also more in the private sectors. The hospitals also, the private hospital contribute almost 60%. So this is very significant when you do a frozen elephant trunk, because the patients also wanted to go in for a private sector. 85% of Indian people wanted to go in for a private private sectors as compared to the Western, as compared to a public sector treatment. And the cost, if you could see, the cost is exponentially high. It is almost 4 times as compared to public sector. The private sector cost is. This is very important because when we asked the industrial data of how many hybrid processes has been sold, I got a data that around 120 hybrid processes has been sold. So this is, mind you, this is from November 18 when the first graft was implanted in our hospital from 2018. From then till the end of March 2024. That is almost close to 5 years. Only 120 grafts has been sold, which is around 20 grafts per year. Almost 1 or 2 grafts per month across the country in India, where 1.14 billion population is there. And there is only 9 of these 20 centers who have implanted the eyebrow processes. 8 to 9 centers have used only one single graft. So, which means that the 10 centers have used the remaining 100 grafts. So that is the equation of this hybrid processes. So the industrial data also says that the 90% of this frozen elephant hybrid processes is sold only to the private sectors, which makes the Indian scenario very specific as compared to the Western population. So where in the European or the American population, the entire cost is borne by the state or the finance by the insurance, but there is no such insurance which takes up the hybrid process, which take up the cost of the hybrid processes. So and in most of these people, it is a double burden, if you could see, because the patient has to pay the hospital bill, and sometimes, not sometimes, most of the time, they have to have a loss of pay at work as well. The other difficult scenario is the warehouse of the hybrid processes. So there are only 2 companies which harbor the grafts here, and these 2 companies have very limited warehouse across the country. So they park because of the less usages, and they cannot keep all the sizes everywhere, and they have to maintain. So they have warehouse as only for, I think, Thermo, if I remember correct, they have only 2 warehouses across the country. So if a particular patient, if a particular center wants it, they have to tell them prior, and then they have to transport it. And in a country like India, where it exports, where it is 3,000 kilometers on either directions, transporting becomes even more difficult, be it patient or the processes, it becomes difficult. And it is even more pronounced when it is becoming an acute scenario, acute dissections. Transporting these hybrid processes becomes very difficult. Another is the lack of awareness from the Indian people, from the patient as well. The patients as well, they may not be knowing about such and such a procedure exists. And if a center tried to explain them, and if another center tried to give them a lower cost for a hemi-arch, they tend to go for that procedure. Meaning that they have to have a second procedure at a later stage. If a chronic type B is going to be happening, they may have to have a second surgery at a later stage. And the concept of aortic super centers which exist in US are not there in our country as well, where the high volume, where a single center has a high volume population, where the errors and the risk comes down and the results are much better. But definitely there is an alternative. There are alternates for frozen elephant trunk which can be done in acute settings. There are, and certain centers, certain procedures can be done, like hemi-arch, hybrid aortic arches can be done, or the branchless procedures can be done in these scenarios where an alternative of frozen elephant trunk, but they are not equivalent to frozen elephant trunk. So here you could see that you deploy reconstruct the ascending aorta, then do a debranching, and then put an endovascular graft. Still, you maintain a type 2 you can have a type 2 endoleak at this region, because the graft is not sealed here. As compared to the frozen elephant, where there is the possibility, we remove the possibility of a type 2 endoleak here, and we tend to put a larger graft here because we size it for the ascending aorta graft. Here, the size of the graft is much lesser. So a new entry point in the distal aorta is virtually very less in frozen elephant trunk as compared to a type 2 hybrid. And this is non-anatomical. So when you want to pass a guide wire, you have to, when you want to take it from the radial, it's very difficult to maneuver and then come down. It's very difficult here. As compared to the frozen elephant trunk, where it is much more anatomical reconstruction, and a second procedure is much more easy as compared to the type 2 hybrid. So what the lessons we have learned is, in Indian scenario, we tend to do patients are much 10 years younger to the Western population, and most of us, our patients come for dissections as compared to aneurysms. And for some reasons, our incidence of paraplegia is much. The Western literature says around 3 to 5%, but our incidence of paraplegia is almost nil. Even when we are doing the antegrade deployment of TVAR graft, we have used almost 20 centimeters from the zone 3. So our paraplegia incidence at that point of time is even 0. We probably don't know whether the anatomy is different in the Indian population as compared to the Western world, or because we do a lot of dissections as compared to them having atherosclerotic burden for a thoracic aneurysm. Still, the answers has to not be there. Frozen elephant trunk has evolved over the last 4 decades, is definitely much better as compared to a classical elephant trunk. Zone 2 implantations and the subclavian modifications has given more advantages in the present world scenario. And the newer devices are coming, which makes our lives more easier. So thank you all for the opportunity. Thank you.
Thanks, Dr. Idris. A wonderful presentation. You've covered the Indian scenario. So I'll ask you, it's very impressive that you're able to do a FET in an acute situation, because that's where the pressure of convincing the patient is so much, because the cost of the FET graft itself is about twice the cost of the surgery otherwise. Right? You add to 10 lakhs extra to the surgical cost. So what is your approach to, as a general philosophy, right? Whether to use the FET in acute dissection or not? If there is an arch tear, right? Do you believe in doing a total arch at that point of time, or does the unit say, if you can afford FET, I will do FET. If not FET, then I will just do a ascending aorta, hemi arch, and come out of it. What is your unit philosophy?
First, frozen elephant trunk in aortic dissection, acute aortic dissection, is having a very good result as compared to, because the dissection flap is very thin. So the long-term results and the remodeling are much better. But in an Indian scenario, we have to be very careful. As you said, the cost. The cost goes to the exception, because the MRP of the Thoraflex graft is almost 11.2, I think, 11.1 or something. So convincing a patient is very difficult. And again, the bringing in the processes material is again going to be difficult. And in acute scenario, passing the guide wire again is going to be difficult. So usually we won't advise a frozen elephant trunk in an acute dissection. Point number 1. Then, whenever there is an arch, whenever there is a tear in the arch, the best option is going for a total arch replacement. Or if you are not able to go in for a total arch replacement, at least possible do a arch replacement at zone 2. Zone 2, replace the arch and proximalize the carotid artery. Proximalize the carotid artery. So we have some landing zone in the Dacron graft, so that in a future stage, get the patient out of the theatre. When the patient comes back, we can land, if that entry point is somewhere after the subclavian artery, we have the Dacron graft for future endografts.
So when you say dissections, they are all chronic dissections, is it?
Pardon me? Yeah, chronic. Not acute. Chronic. We have a very limited acute, very limited.
Thank you.
This actually, we had a problem recently, like one acute aortic dissection I opened up, and then there was an aberrant right subclavian. So, and there was a tear at the level of the aberrant right subclavian also. So, is it possible to, I actually replaced the entire arch, I went up to the aberrant subclavian, detached it and re-anastomosed here, and then managed with the graft. But is it possible to manage it with a frozen elephant trunk if I had one? So, it's a complex situation, I know, but any experience or anything?
I think 3 months back, in our journal, we published a case of rubber and right subclavian with a frozen elephant trunk. 3 months back we did so. So what we did was actually deployed the frozen elephant graft at zone 2, that is between the carotid and the left subclavian artery. So there we deployed the graft. The frozen elephant trunk graft was deployed. And then what we did was from the radial, we passed a guide wire on table and put a plug into the aberrant right subclavian. So we sealed off to remove any endo leak, and then we anastomosed to the infraclavicular region of the right subclavian artery, brought it intrathoracic, and the side branch of the fourth branch, which we use for distal perfusion, used that branch for reconstruction of the left subclavian artery. This was one. And there was another series from Bologna where they did was actually they harvested the apparent right subclavian artery just lateral to the trachea. They brought it, they surgically divided it, and then they brought it and anastomosed there. So, but we have to be very careful there, because there, if we at all, there is any problem, we may lose the vocal cord, because already the left vocal cord is at risk because we are doing an arch surgery, and if we damage it post-operatively, we may have problems.
Thank you, Idris.
Thank you.
So next two talks will be based on ventricular assist device, and first talk will be given by Julius Punnan on LVAD, the patient selection, optimization and perioperative care.
Thank you, Jayagumar, for being considerate to vertically challenge people by keeping a little stool here. Good afternoon, everyone, and thanks once again for giving me the opportunity to be here. This is the town when I went to school, so it is very nice to come back here. Now, surgeons have been addressing heart failure mechanically from a very long time. There was this thing called southeast tubes, which were put into the legs to drain edema fluid, which made it a more elegant solution, because prior to that it was only incisions on the leg, which just freely drained fluid. So subsequently this was doubled in its diameter to provide longer term drainage and better drainage. From there we have come a long way, and now we have very sophisticated devices in the pipeline. This is something which I took pictures of last week at their stall. This is a pump which is being tested now. It is not in the market yet. This is an intraventricular pump. It responds to systole and diastole by having an ECG lead placed on the heart. It varies speed and produces pulsatile flow, and there is no drive line. It is transcutaneous charging. So these are things which you can hope for in the future. We were spoiled for choice in the past. We had all these pumps available in the country, but now we are left with only 2 pumps, of which one is on a temporary withdrawal. So we have only EVA Heart at the moment. We can get HeartMate 3 and 2 also, but 2 probably will be out by July. So that is all we have now. Now, when you look at these various classification systems in heart failure, so we started everything with NYHA, and everything was based on that. So stage 4 in NYHA needed subdivision because all stage 4 is not alike. Then we came up with this whole intermax profiling, where it goes from 7 to 1, where 7 is relatively stable and 1 is unstable. And again, the profile 1 and 2 were further subdivided into SCI groups based on the shock and the condition thereof. So we are looking at the group which are relatively stable, not so unstable, to do LVADs on. So this is the SCI classification of shock, which is not a very relevant thing for durable MCS, but it's certainly relevant for temporary MCS, because that is what is used in treatment here. So selection of patients for LVAD is one of the most important things which you must stress on, and based on selection, your outcomes on the short term and the long term can vary a lot. Like if you're going to take on patients who are intermax 1 or 2, the mortality can be quite high, even though some centers do them with acceptable mortality. In the registry, the 1-year mortality of intermax 1 is about 40%. So, it is something to keep in mind. Now, it is also that if you look at patients at an earlier part of their disease, they do not gain any mortality benefit by putting in an LVAD. And when you're in shock, if you put in a durable LVAD, you're unlikely to survive. So you really need to find that sweet spot where, usually somewhere between 4 and 3 is when you want to do the implant. But remember, 5 weeks too early in the implant is better than being 5 minutes too late. The first study that showed the importance or superiority of LVAD over medical therapy was the rematch trial. Rematch trial actually had to be closed early because the results became fairly clear quickly. And again, we must remember we were using a very old machine in that. Is there a pointer there? I can't get this pointer to work. Sorry. So my only experience with the HeartMate XV is this one where we had explanted after 9 months of implantation during my training. Since then, we have had several other nice devices, and this is the results from the Momentum 3 trial, which compared HeartMate 2 to HeartMate 3, and there is a 54% event-free survival at 5 years, and 58% survival at 5 years. So this is almost nearing heart transplant results. It is conceivable that at some point they are going to be equal, because heart transplant results are really not improving. Numbers are also not improving, but these machines are getting better. So it is likely that these results will sort of equalize or get better at some point. That is provided this industry continues. There are a lot of challenges they are also facing. So you can see in comparison between these two devices, the HeartMate 3 has been a major improvement over HeartMate 2, and the risk of GI bleeding has come down a lot compared to the earlier ones. And also now there is a move towards not giving aspirin to these patients. So GI bleeding has become really not a big problem anymore. Now, there are a few situations where we use various types of LVAD, either as a bridge to recovery, which can be in a post-cardiotomy shock or sometimes postpartum cardiomyopathy, generally thought to be reversible ones. So a lot of times we can use a temporary MCS, but other situations you may have a durable MCS and people tend to recover over months or years. And it can be a bridge to bridge where it is a bridge to another device, or most commonly as either bridge to transplant or bridge to as destination therapy. So the main indications are severe heart failure, which is not responding to medical treatment, and it is good to remember some of the major contraindications at least, which is about assessing the right ventricle, and also chronic hemodialysis is considered a relative contraindication for LVAD therapy, because it becomes a little difficult to dialyze these patients who are on continuous flow, and many centers do not accept them for hemodialysis at all. In preoperative assessment, it is all about assessing the right ventricle when you're looking at the heart. There are various indices which are used to calculate if the right ventricle is likely to work or not, but none of them are perfect. So if you have a patient who's got a very high CVP and low peer pressure, that would tell you that these people are unlikely to have a good right ventricle suitable for LVAD. If there are any shunts in the heart, even if they are very small PFOs, it has to be shut, because they will produce a large right to left shunt once you put the pump in. And all the other assessments have to be done meticulously, and all patients should be optimized very well preoperatively. Sometimes I spend about 3 weeks keeping them hospitalized and drying them out. What is said is, like, if you light a match next to a LVAD patient who is well prepared, he should catch fire. You should dry them up so badly, it should be like a dry leaf. You do whatever rehabilitation you can do. Remember, we hardly ever take a patient as emergency, so spend time correcting whatever can be corrected. Just a few slides on the procedure. You have to mark the driveline exit site in consultation with the patient based on his habits and where he wears his pants and belt, etc. In HeartMate 2, you need to create a very generous pump pocket, and you make the driveline exit site as, you can see the driveline exit site. Is there a mark? Yeah, there is a marker here. So this is the driveline exit site. that is done first. Usually it is done ahead of the other procedures. Before heparinization also you can do that. Then you mark the site for apical coring. Do the apical coring depending on the device. Each one comes with its specific knife. And remember, the apical coring that is what determines how the pump sits. So it should not face towards the septum. It should directly align towards the aortic valve. Now in HeartMate 2, you have the sewing ring like this, which are used with pleated interrupted sutures. In HeartMate 3, the ring is a little different. It can be either you can sew the ring in and then make the core, or you can core and then stitch the ring in. Either way you can do it. There are some newer rings which are available which make things much easier to insert. The next thing is to insert the pump. For HeartMate 2, you will have to place it inside that ring and tie it. In the HeartMate 3, it just clips onto the ring very easily. Just have to make sure these yellow portions on the clip are gone inside to engage it fully. Then you anastomose the aorta, the outflow graft to the aorta. In HeartMate 2, you can actually do this early. As soon as you go on bypass, you can do this and get hemostasis there, and then connect later, because you have a dummy sizer. With that you can tell accurately where it sits. You need to do de-airing very meticulously, because two things. One, the LVAD should not suck any air, so it has to be airtight that side. Otherwise you'll get air sucked in and delivered into the right coronary, and the right heart will fail. So de-airing is extremely important in this situation. So you can see post-implant, there should be streamlined flow between the mitral valve and the pump. If there is any concomitant operations that can be done, it is important to evaluate for any shunts once you go on pump, because you may not see a PFO shunt before you decompress the left side because of the high pressures. Coming off bypass in these is an art. You have to carefully monitor all the various monitors, including the TE, and reduce the pump flow gradually and increase the LVAD flow. You don't have to really attain full flows at the end of the operation. You can do that over a few days if you like. Then take care of the right ventricle. That's the thing you have now. Just another minute and we'll be done. So sometimes you do get right ventricular failure, which will need use of a temporary RVAD. You can see that you used a centrimag pump here with a graft going subsiphoid for the inflow of the centrimag. There are lots of complications that could happen with an LVAD, and bleeding, stroke and driveline infection probably would be the important ones. Now, LVAD is likely to be here to stay, because heart transplant numbers are not going to go up much because of donor shortage. So we should get used to looking after patients who don't have a pulse. And we will be getting newer devices which are much better and more durable, and some new total artificial hearts are also in the pipeline which are likely to be good. Thank you very much. So this is, for those who don't know, it's a Saint Catherine who apparently got her heart taken by Jesus for 2-3 days, and then he placed his own heart there. So likely that it's a bridge to transplant with MCS.
Thank you very much, sir. Just one question, since you probably have a large experience, and in our Indian situation is different. What is the quality of life of our patients post-LVAD? Because our Indian scenario is different from the West.
See, one of the major problems we have seen with driveline infections are with the Middle Eastern patients who come here. I think on all the patients who have implanted LVADs from the Middle East, they have had driveline infections. So with Indian patients, I don't see a major difference except the affordability, which can be a problem, because HeartMate 3 is currently about 80 lakhs, EVA Heart is 60. Now for the next month or two, HeartMate 2 is available at 15 lakhs for clearance sale. So that is one of the problems. And when you're using heart rate 2, you require a certain body size to be able to do it. But an average sized Indian patient is fine. It's only for smaller people who you may have a difficulty. With heart rate 3, it's okay.
One more in a broader perspective. Suppose a patient presents for end-stage heart failure and you're evaluating him for transplant. Which patient goes to LVAD, which patient goes to transplant?
See, what I do personally here, we don't have so much of a shortage of organs in this country as compared to the West. At least some areas of the country. If you look at other areas, it's probably there. So if somebody is suitable for heart transplant, I would offer transplant first. See, if they are not suitable for transplant, then LVAD is an option. There are others who just choose, as in the patients say that I don't want transplant, I want an LVAD. So, some people like to have something as expensive as a Mercedes sitting inside their chest. So it's up to them. If there is a contraindication to heart transplant, like if it is irreversible pulmonary hypertension, for example, that would be a situation where I would offer an LVAD. And then, after you unload the ventricle for a sufficiently long time, you reassess them for transplant. And again, when you spend this kind of money, nobody wants to do another procedure after that.
That brings us to the other question, that every time you consent a patient for an LVAD, in the back of your mind, the fear is that if he needs an RVAD also, in spite of your preoperative evaluation. So do you convince them that you need to have 80 lakhs standby in case you need an RVAD, or?
No, we use a temporary RVAD. The Centrimag is what we use.
Yeah, but what if he doesn't come off?
No, I've not had to use, because RV evaluation is never perfect. We can do all these tests, but still you may be stuck with a non-functioning right heart. So next thing is to use a temporary RVAD. You cannulate in a manner that you don't have to take them back to theatre for removal. So you would put a femoral cannula for access and stitch a graft to the PA for return and bring it out. And when you're removing it, you just pull it out and cut it.
Thank you.
So you could keep an RVAD for several weeks.
Anything from the floor? Thank you, sir. We'll call the next speaker. Dr. Jyoti Muthu to talk about the Berlin LVAD.
Good afternoon. I know it's the last talk, and I'll try to keep it as precise as possible. So this is about Berlin heart BioVAD as a paradigm. I mean, as a perspective in VAD therapy, and it's my experience or our institutional experience with one patient. Now, the Berlin heart XCOR device offers time and hope to children suffering from severe heart failure. It was developed in Germany. Innovation that acts as a temporary bridge until critically ill children can get a heart transplant. The Berlin heart mechanical heart is a ventricular assist device for children with severe heart failure. It is an external pump that supports cardiac output. It uses polyurethane housing material and carmida as a bioactive surface coated chamber and tubes to connect to the heart and aorta, and powered by air from a driving unit. So provides enough support for cardiac output to have a heart transplant, protection from organ damage, increases blood flow and oxygen delivery, allows the heart to regain strength to even sometimes removal of the device without a need for a heart transplant. Now benefits over LVAD is that it's a pulsatile flow. Emptying of heart and blood volume needed can be assessed by visualizing the chambers of the Berlin heart. It's easy mobility, quick identification of clots, there's no reversal of direction flow, easy management of anticoagulation, though it is said that, but we had a lot of problems with maintaining anticoagulation. Minimal wear and tear of blood cells. It's only available VAD for the neonatal and the pediatric population. So this is how it is. It's got the inflow cannulas, and then the driving unit, the outflow cannula, the driving unit, and then finally the computer with the battery. So our patient is a patient who had dilated cardiomyopathy. And it's a common cause of pediatric heart transplant, but donor scarcity is a global problem, and it's a big issue in our country for such small kids. So our patient was a 4-month-old, it's 2 years and 4 months old girl with dilated cardiomyopathy, from UAE, came to cardiogenic shock, severe mitral regurgitation, has had multiple cardiac arrests in her country, revived and sent on a ventilator to our institution. She was extubated in December 2022, and we kept her on in and around Delhi, our hospital, for waiting for a transplant. But unfortunately on 31st of May, she had episodes of acute gastroenteritis followed by a cardiac arrest. Now, the resuscitation took nearly 40 minutes, but we did get the heart back. We were not sure whether her neurological status is going to be okay. But in 2 to 3 hours, she woke up, she started moving. So her CNS was okay, but she went on adrenaline, dobutamine, milrinone and calcium. Now the thing was, we were not able to wean the ionotropes at all. There were days when she was good and we would think that, okay, we'll try to reduce the ionotropes. Even if we reduce the adrenaline from 1 ml to 0.8 ml, immediately she would go into low cardiac output state. Her peripheries would become cold, the urine output will start coming down, lactates will go up, and there will be some kind of frothy secretions in her ET. And she also became very ventilator dependent. In between all this, she was positive for blood cultures, various organisms, Klebsiella, Candida, multiple antibiotics. And with progression, with time, we found that her increasing MR and decrease in EF, and she also needed a tracheostomy at this stage. And this continued, this inotropes and ventilatory support and treating with multiple antibiotics continued for nearly 2 months. So that's the kind of MR that we were seeing. So in the intensive care, every day we faced problems. There was no IV access. Central line insertions were leading to either hemothorax or pneumothorax, not able to wean inotropes even a 0.1 ml, and multi-organism sepsis. So preferably, we got stuck with this child and we wanted to make some progress. So the options were for ECMO support, Berlin heart BIVAD. We thought of BIVAD from the beginning because the lungs were also getting into a bad situation because of repeated pulmonary venous congestions, and we found there was increasing TR, and the pulmonary hypertension also was a little on the higher side. Though we did not do a cardiac cath, it's all echo, it was all delineated by echo. So finally we thought, agreed for BIVAD implantation despite positive cultures. Now positive cultures is a contraindication for implantation, but we had no other choice. ECMO for long durations was not a viable option due to bleeding and CNS complications. So this is what it looks like. You have a separate RVAD and LVAD, and this you can see, these are the 4 tubes that you can see, one from the right atrium and goes into the pulmonary artery, and one from the LV apex going into the aorta, ascending aorta. Now the good thing was that we were able to close the chest immediately, give protamine, and there was no bleeding. She was off inotropes within 3 hours after the procedure. She was extubated, her tracheostomy was removed, and surprisingly, after the institution of Berlin heart, her blood cultures also became negative. So this is how it looks. You have a left-sided and right-sided thing on the computer. You can control the heart rate, and you can control the amount of blood pressure that can be generated for each chamber from the computer from outside. And it was the first time we had a lot of problems. We had formed a group with the Berlin heart people, and we used to discuss with them on a daily basis, showing them echoes and then getting their advice about how to play around with this machine. Now, so this is how it looks. The diaphragm, it keeps moving, and the way it fills up fully, it indicates that it's emptying and maintaining good cardiac output. We also need to look for clots around these tubes, which we have to regularly use, and we used to update this to the Berlin heart people, and this is how the 4 of them are there. Fortunately, we were doing dressings every day, and we did not have any kind of infection at the end, at the exit points. So in terms of mobility, this is as much as we could mobilize with the whole drive. It's got a battery which can last for about 40 minutes. So we could bring her outside the hospital. But not real mobilization, not in a position to send the child home. So in the meantime, when she was on LVAD, we found that there were 2 embolic episodes. Now that was because we were not able to maintain adequate INR. We had to keep them on 3 anticoagulants, especially for this kid. We were not able to identify why. So she was on aspirin, and she was on azithromycin, and she was on IV Clexin. Despite all this, in between IV heparin, we were not able to maintain adequate INRs. But the 2 episodes were related to 2 times where we were told that there would be a heart available, but eventually it was not available. So because we were told the heart is available, we had to switch off these anticoagulants, and by the time we could restart the next dose, on either side of the brain she had a minor stroke. And multiple anticoagulants, mobility very restricted, and the alarms were coming out from the machine, left, right and center. We did not know how to look after it, but then we used to come every night and we used to have video conferences with the Berlin Heart people, and they helped us a lot, and now I think I'm a little more comfortable using this machine. And donor organ scarcity was a major problem, but we started looking for organ more vigorously. Finally, the donor was procured after 4 months, and you can imagine the reopening of the chest was a kind of a nightmare with 4 tubes sitting right behind the sternum from one side to the left side. But we opened it carefully and went on bypass, explanted the Berlin heart, and we successfully transplanted. Now, presently she's extubated off inotropes, on anti-rejection medications. The neurological recovery is also quite good. Nearly 90% of her neurological complications have resolved. Now, as of now, she got discharged home as well. Now, so where else can be used in pediatric cardiac surgery? One place is in failed Fontan. It's believed that, it can be used in the right side, where the only difficult thing is you have to undo the glen and then create a fenestration, if it is an extracardiac, between the tube and the right atrium. And this cannula is inserted through the graft, through the fenestration into the right atrium. And so it picks up all the thing, and then it is connected to the pulmonary artery. I have not seen a video of that, but I don't know, it may be very difficult with all these glen anastomosis, which needs a patch. I don't know, if somewhere we'll have to stick in the outflow into the pulmonary artery. And occasionally they've also used it as a bivalve. If the ventricle is also failing, just use it as from LV apex to the aorta. Now there are only very scanty reports of 2 patients where this has been used in a failed Fontan in a pediatric cardiac surgical setup. So that's about it. Thank you.
Thank you. Excellent presentation. Obviously, you had resources was not a problem. That's why money was not a problem. That's why you were able to manage this patient so well, right?
Money was not an issue. Okay.
I just had a question that your patient was not the ideal patient to go on a VAD because she had pulmonary edema and she was off and on going into pulmonary edema as well, right? So now once you put all these cannula in, you weaned her off bypass, and suppose you found the oxygenation wasn't good and you needed and she did a temporary ECMO. Where would you have put the ECMO? Because everything else is taken out, right?
Well, the idea was we were told that we can go on ECMO just as normally.
You got
put a cannula in the distal aortic arch and then put an SVC IVC cannulation. This RA, the inflow graft was the outflow from RA for the right side was from the right atrial appendage. Okay, so still SVC and IVC was there. So we were told that if it needs an ECMO support, then a distal aortic arch cannulation, SVC and IVC cannulation. We were ready for that, but luckily it didn't happen. Yes, we did. She was actually on bilivarodin as well. But despite that, there was some problem with her liver because of...
After bivalirudin became the standard of care.
No, we are using only bivalirudin. It is what is being used on all patients.
Thank you very much. We'll have to end the session now. Thank you very much.
Thank you.
Thank you very much for a very interactive session. Now we have a short Validic 3 function. May I invite Dr. Manoj Sureraj, President IACTS, Dr. C.S. Hiramath, Secretary IACTS, and Dr. T.K. Jayakumar, Organizing Secretary of Iacts Techno College 2024 to be on the stage. We are now giving away the prizes of the quiz competition which was conducted yesterday. I request Dr. Rajesh S., who bagged the first prize for the consultant quiz yesterday. Dr. Rajesh S., please come forward. I request Dr. Manoj Sureraj to give away the prize to Dr. Rajesh S. He was the quiz winner yesterday. Please, sir. I call upon Dr. Prithvi and Dr. Deepak from Sri Chitratirunal Institute, Trivandrum, to come to the stage to receive the prize for the first position winners. Dr. C.S. Hiramat, please give away the prizes to them. Dr. Arun and Dr. Parvati from Trivandrum Medical College bagged the second prize for quiz. Please come forward and receive your prize from Dr. C.S. Hiramat. Over to Jayakumar sir after this for the vote of thanks.
Yeah, I'd like to thank the organizing team, especially the chair, Dr. Ram Narayan, the organizing secretary, Dr. Jayakumar, the joint organizing secretary, Dr. Vinita, and all the members, faculty, delegates who have participated in this fantastic academic feast along with a beautiful venue. I'd really like to congratulate all of them from the bottom of my heart on behalf of the IACTS and the executive committee, and also on behalf of Dr. C.S. Hiramat. Thank you very much. I think we can all wind back, and you guys need to take a little break now. Yeah. Thank you very much.
Thank you. And respected President, Secretary, and other distinguished delegates, it is my pleasure and privilege to give a vote of thanks. And first of all, our IACTS President and Secretary who guided us through all this and helped us to conduct this conference here. And thank you, Dr. Manoj, and thank you, Hiramat sir, for all the kind help and all the support that you have extended. And my sincere thanks to all the executive committee members and the Mumbai office and the Satyasai office who really supported us. And then the faculty members who traveled across and who were here, especially Tendulkar sir and all the senior faculty for being here and delivering and sharing their experience, which meant a lot for us. And then all the delegates and students who are the participants who really made this, the entire program a success by their contributions and discussions. Then, of course, the industry. We have the main supporters like the Merrill, Edwards, Sentinel, J&J, and the others like Healthium, Teleflex, and all these fellows, all these industries who are really supported us so that we could conduct this meeting here in a proper way. And they also supported us with the wet lab and the robot here. So very big thanks to the industry for really supporting us through. Then we have the organizing committee, my respected teacher, our Ram Narayan sir, and all the organizing chairmen like Praveen, Vivek, and the entire team, the cardiothoracic team. I don't have to say thanks to them because they are part of my heart and my family. And really hats off to you, my dear friends, my colleagues, Dr. Vinita, Nidish, the entire team for being here and helping us. Then of course our light and sound fellow Pradeep is there, and then the events who organized the stage and the cultural things and the BACKWATER ripples for all the help. Thanks once again. Thank you all, and thanks once again. Thank you.
I request all of them, team of Jayakumar to come up for photograph fast. Otherwise, I will miss my flight. Come. And I request Idris and Matthew also to join us. Executive member Dr. Jagannath, please come up. Come up fast. One group photo. All the team members, no need a special one by invitation. You know, receptionist who are sitting, everybody come down. All our team members. Some can sit in the front and we will stand. Be little fast, please. The other people also can join us, sir. Baiju and where is Baiju? Hey, please come, sir. No, you have given a good talk, sir. Please come. All student delegates also join us. It's a group photograph. A memory of backwaters also. Be fast. Try to find space yourself. Who is the photographer not seen? Fast. Dr. Nitish, yeah, please come. Some people can sit front also, no problem.
Come in front, camera.
Then tell us when you are ready, please. Santosh and Shankar also join. Please join.
I would like to extend a sincere thanks to Mr. Santosh, who was the backbone. Like, he is from the industry, but he was part of our department. Like, he organized most of the things around. Thank you, Santosh, for the wonderful work you have done. Thank you. I told them, like, actually last 4 days he was with us. We conducted a metabolic repair workshop, excellent audio visuals. Now also he was continuing with that. Thank you so much. I expressed that. Thank you so much.
Thank you, sir. It was excellent.
I request all of you to please stand up for the national anthem. Vinita.
Check.